everybody. A warm welcome to the second certification course TB webinar, which is going to tell you all about what is new in diagnostics and treatment in MDR TB. This is an excellent initiative by the BD, which is endorsed by our Indian Chess Society, the Central TB Ministry, and the Union. We have a bunch of fantastic faculty who are absolute authorities in TB, and they're going to give us fantastic information today about what is the importance of midget cultures and sensitivity, the genotypic sensitivity, and the treatment of MDR TB and the problems that we come across while treating patients with MDR TB. I would like to initially have 3 fantastic talks, which will be followed by a very interesting panel discussion. I would like to thank our Indian Chess Society for this wonderful academic initiative, especially our President, Dr. Sandeep Salvi, and our Secretary, Dr. Rajadhar, for making sure that every Wednesday we keep on learning everything that is so very clinically important to us. And a huge big thank you to our academic partners, BD, for supporting our academic endeavors. So with this, I'd like to start the first talk. I'd like to invite the star microbiologist of our country, Dr. Ashok Ratan, who actually requires no introduction at all. Dr. Ashok Ratan is a very senior microbiologist known to everybody in our country and also across the world. He has more than 25 years of experience. He has held very, very important academic positions in every important association and institute of our country, whether be it AIMS or JN Medical College, Aligarh, or the Mahatma Gandhi Medical University, Jaipur, and so many other places. He has more than 100 research papers in national and international journals. And most importantly, he was conferred API Abdul Kalam Award for lifetime contribution to medical sciences in 2018 and Srinivas Oration in 2021 by Indian Association of Microbiologists. With this brief introduction, over to you, Dr. Ashok Ratan. We are looking forward to you enlightening us. Thank you.
Thank you for your kind words.
I think before Dr. Ashok Ratan starts, I would definitely like to introduce you, ma'am, over here on this platform. That is, definitely you don't need any introduction. Each and every member over here, chest physician in India, knows who Dr. Amita Nene is. But still, it's my honor to introduce you on this platform officially. None other than Dr. Amita Nene, who is program in charge and TNB teacher of respiratory medicine, MD and DNB examiner for pulmonology. She has been awarded as the legend in pulmonology by Health Ministry in July 2023. Named as leading Indian women pulmonologist in respirology, that is 2022. Author of more than 50 plus publications and 12 chapters in pulmonary textbooks. Honored by a secretary of Indian Association of Bronchology, member of a board of reagents for WABIP, West Zone Chairman of Thoracic Endoscopic Society of India, governing body member of Indian Chess Society, and recipient of Young Achiever Award in field of pulmonology. By this, now we hand over the platform to Dr. Ashok Ratan sir, and let us be obliged by his enlightening over here. Thank you, sir. All to you, sir.
Thank you very much. Thank you for your kind words. Can you see my slides?
Not yet.
So your slides are active, sir.
All right. So today we'll deal with critical role of DST in TB diagnosis. You know that in 2015, NTB strategy was unveiled, and it has 3 pillars. And the first pillar had 2 very important strategies. One was that rapid diagnosis of tuberculosis, and the second one was universal drug susceptibility. Since 2020, there have been a number of publications by WHO consolidating guidelines on the diagnosis of tuberculosis. And recently, Madhuka Pai and Soumya Swaminathan, along with Puneet Diwan, had published in Nature talking about transformation of TB diagnosis, and they came to the conclusion that testing is the weakest link in diagnosis. I'll move it. So WHO has approved 5 diagnostic methodologies for initial diagnosis of tuberculosis. They have made the recommendation. Somebody is moving the slides.
You can move it, sir. There's no other interference, sir.
So they have made the recommendation that these tests should be used for initial diagnosis. It was also implied that we should not be using smear diagnosis for making the initial diagnosis, partly because this is something that Robert Koch has used in 1882, where we were moving around in bullock carts, and it is not sensitive enough. It needs 10 to the power 4 bacteria to be present. That would mean that the person will come 4 or 5 times and the smear microscopy will be negative before the disease has progressed enough to be detected by smear microscopy. In the meantime, he would have infected 5 to 15 persons. In a recent publications from WHO talking about universal access to rapid tuberculosis diagnosis, they indicate that in India, only 20% of the diagnosis in 2021 were made using molecular methods, while even countries like Zimbabwe has about 100% molecular diagnosis. This actually means not only that we are not diagnosing quickly enough, but we are also losing the opportunity to perform DST on the isolates if we are making the diagnosis on the basis of smear microscopy. Now, the diagnostic field had a change for the better with the introduction of cartridge-based single-use CIFED cartridge, and the first cartridge had a sensitivity of 131 bacteria, which has now been reduced to 16. The principle of this was that RPOB 191 base pair of RPOB gene would be amplified, and once it's been amplified and reported as positive, then 5 overlapping probes will look at a 81 base pair region of the RPOB gene, which is known as the rifampicin resistant determinant region, RRDR, and the mutation in that would mean that there will be resistance. So this is detection of resistance or detection of mutation and presuming that that will mean resistance. That means that this cartridge, which is single use, disposable, would give 2 very vital informations in 90 minutes time. One, whether Mycobacterium tuberculosis is present or not, and second, whether if present, whether it is susceptible, whether it is resistant to rifampicin or not. On the basis of this, it was suggested that we should then start treatment. Unfortunately, it has now appeared that the assumption that susceptibility to rifampicin also means susceptibility to INH is wrong. And you can imagine that if there's resistant to INH but susceptible to rifampicin, and we presume that standard treatment will be given, for 4 months of the continuation phase, we're giving monotherapy. In 2020, WHO also approved 4 new tests, which are classified as moderately complex automated nucleic acid amplification tests, which not only detect Mycobacterium tuberculosis, but also simultaneously report on the presence or absence of mutation in INH, That means CATG gene, or the other target is INHA gene. So whether there's any mutation for leading to resistance to INH or to rifampicin. And since they detect multiple antigens, multiple genes of Mycobacterium tuberculosis, the sensitivity of these methods become much more. Now, when you compare smear microscopy, which needs 10 to the power 4 bacteria, Gene Expert, as I said, had a limit of detection of 131, and Gene Expert Ultra made it 16. BD Max would detect 1 bacteria. And this will all be reported in 2 to 3 hours time. BD Max takes 4 hours to report 24 samples. So all this will give results very fast, while culture would take 6 to 8 weeks to report. That difficulty was overcome initially by BACTEC 460, which went out of use because it used radioactive isotope for detection, and it was semi-automated by a new system known as BACTEC Midget, which is an automated system. This automated system is based on using a tube which has a fluorescent dye embedded in the tube. It has liquid culture, and if the bacteria grows, if Mycobacterium tuberculosis grows, it will consume oxygen. As the oxygen is consumed, then the fluorescent dye, when exposed to ultraviolet light, would give rise to fluorescence. Once the bacteria has grown, then it can be identified within 15 minutes by doing lateral flow looking for antigen. This antigen cannot be used for direct sample testing on the sample because it's not sensitive enough. But once the bacteria has grown, then by lateral flow, in 10 minutes time, we can identify the isolate as Mycobacterium tuberculosis. Once that has been identified, we can do the next step. Many years back, when Dr. Bansidhar and I, we both were in SRL, we had processed 500 samples, both with Midget 960 and LJ medium. And we found that out of 500 samples, 391 grew in Midget, while only 204 grew in LJ. And as you notice here, in the first week itself, we started getting positive results with Midget, while for negative results for LJ, it was much less and it took longer period. Therefore, culture, which is supposed to be the gold standard, LJ was the gold standard. I think I would submit that Midget is the gold standard for diagnosis of tuberculosis. Once you have isolated the bacteria, then you can do phenotypic drug susceptibility testing. This will help guide choice of chemotherapy. It will confirm emergence of resistance, especially in partially treated persons, and it will be useful for surveillance. In this differs, the sensitivity of Mycobacterium tuberculosis differs from sensitivity of, say, rapid growing like E. coli and others, in the sense that we are using only one concentration, which we are calling as critical concentration, which is defined as the lowest concentration of the drug that will inhibit the growth of 99% of wild type population. WHO has also defined clinical breakpoints, which have been defined of the same drug concentration above critical concentration that separates susceptible strains from resistant strains, which may be useful for clinical decision making. This is one example that, since we know that is mutation in the target gene which leads to resistance, we can then have a collection of resistant strains and wild strains where there's no resistance, and then do the minimum inhibitory concentration, and you will be able to identify a critical concentration below which everything is sensitive and above which the that this differentiates between resistant bacteria from sensitive bacteria, and that is the critical concentration. So for all the drugs, critical concentration have been defined, and it can be done either in LJ or it can be done in 7H10 agar or 7H11, but preferably it is done in midget tubes. Now, WHO has endorsed three methods: Lowenson-Jensen, Middlebrook 7H or 7H11 or 7H10 or midget. Initially, they had endorsed midget Bactec 460, but now, of course, 460 has gone out of use, and so it is midget 960, which is the one which is endorsed, and this will get you results in less than 10 days' time. We need to also understand that what we are doing is not generating resistance, but selecting the drug-resistant mutants. Spontaneous mutation will occur in the target gene when and each time the bacteria divides. One bacteria out of 10 to the power 6 or 10 to the power 8 will become resistant. That is an act of God. But we select for resistance by selectively putting pressure, and that resistance this is how resistance is created. Let me explain. Mutation in the target gene leads to resistance, which is an act. How are these genes? So this will lead to resistance. Now, if you give right treatment, then all the resistance, because the other drug will be active, will wipe it out. But if you give monotherapy, then as we discussed that you're presuming resistance, rifampicin sensitivity is also INH sensitive and the isolate is INH resistant, then there'll be amplification of INH. The next round will be that when you give INH, then rifampicin resistance, which is one of those which when they multiply, there'll be rifampicin resistance. And when rifampicin alone is given, which is effective, you would have resistance. And that is how MDRs are generated. At this moment, for treatment of drug resistance, now we have three groups of antibiotics. And we have the choice that one, we can use a slow method, which is like using a tortoise to identify phenotypic drug resistance, or we use midget, which will give us results in 10 days time or so, or we have the option of using a baby elephant like next generation sequencing, which is emerging as the right method. Let me explain more about phenotypic drug resistance. The moment we have rifampicin drug resistance, to identify what drugs will be used, you need susceptibility results of moxiflox, linezolid, clofamazine, delamide, and bedaquiline. And this is normally done because we're looking for 1% resistance. We have two dilutions used of the drug susceptibility. One is undiluted and the other one is diluted 100-fold. And then 100-fold diluted is put into growth control, and the concentrated one is placed into tubes containing different concentration of the drug. And this then we have a race to see whether the growth will grow better or the growth in the presence of the drug will grow. And overall, they've noticed that there's a lot of resistance available existing against rifampicin, INH, and ethambutol, which are the traditional ones, and moxiflox and levoflox are also emerging. But as you know, notice that bedaquiline, delamide, and clofamazine have less resistance available. Another thing we need to consider is the mutation prevention concentration. There is, we know about MIC is the minimum inhibitory concentration. The drug is not effective if the concentration is below MIC, but once it crosses MIC, it will start killing the sensitive ones and the resistance one would be. So unless the drug level reaches higher than another concentration known as mutation prevention concentration, the difference between MIC and MPC is the mutation selection window where resistant mutants will be selected. Let me explain here. Rifampicin, streptomycin, and INH have excellent activity against Mycobacterium tuberculosis. But if you pay attention not to the MIC but to the MPC, mutation prevention concentration, you find that they're not very good as mutation prevention concentration. Therefore, whenever you use rifampicin, streptomycin on INH, you would kill the sensitive ones, but you will select for the resistant ones. On the other hand, if you use moxiflox or Getiflox, you will notice that they not only have excellent MIC, but also excellent mutation prevention concentration. So what this information is required for selecting new drugs, that they should not only have good MIC, but they also should have good MPC. And this MPC should be higher. The higher the Cmax, the better would be the result that you'll get. Now, we are in the beginning as far as TB is concerned of understanding what is the Cmax, what is the AUC, what is the time over MICs of most of the anti-TB drugs. It's also been noticed that there is more death in ICUs when a TB person enters because the pharmacokinetics and pharmacodynamics are disturbed and breakpoint needs to be changed. So at this moment, there's a feeling that not only the microbiology, but also therapeutic drug monitoring of TB drugs should take place. Nevertheless, at this moment, we know that there are 18 drugs available and there are 32 genes which are the targets for these 18 drugs. So if we can detect whether these genes are wild, that means sensitive, or mutation, that means resistance, we would be able to then make a choice of what drugs to use. WHO as well as Government of India, ICMR has published the collection of mutations that are in these drugs, these genes, and the methods available are whole gene sequencing or targeted drug resistance testing. And this is whole genome sequencing but targeted, so that only these 32 genes are tested. And at least 2-3 companies in India are already doing next generation sequencing. Recently, and they would not only report what drugs that they're there, what are the genes which are the target, and what mutations are there. Recently, Haystack had published published the results of their reports from Mumbai. And as you notice here, there's mutation against the common ATT drugs, but the new drugs are less. Just last week, I think the same group has also indicated that Indians have a lot of pre-XDR strains are available in Mumbai. And again, the same as you notice, that majority of the new drugs are sensitive. This is useful not only for drug resistance, but also for lineage. So for epidemiology, it may be useful, and also finding out what are the drugs which you can use if you are not still having the result. So in conclusion, I would say that liquid culture has a number of pros to its credit. It's rapid, it's more sensitive, it's suitable for drug susceptibility testing. New drugs can be used. The cons are that it requires BSL-2 facilities, it's technically demanding, and about 5% resistance can occur. Finally, the rapid results are there, more sensitive because 10 bacteria can be isolated. both both Mycobacterium tuberculosis and Mycobacterium other than tuberculosis can be identified, and new drugs can be tested. So I would suggest that there's a critical role of midget liquid culture in the treatment and diagnosis of tuberculosis. I hand you back to the moderator, Dr. Nene.
Yeah. So that was a fantastic presentation by Dr. Ashok sir. And now over to our next speaker. I think question answers we'll be taking at the end if the time permits. We are already running late. So our next speaker today is none other than our own Dr. Sanjeev Nair. Dr. Sanjeev Nair is additional professional Department of Pulmonary Medicine at JMC Thrissur. He is additional professor over there. Chairman Zonal Task Force for Medical Colleges NTEP South Zone 2, that is Kerala, Tamil Nadu, Andaman and Nicobar and Puducherry. Chairman State Working Group for Latent TB Infection at Kerala. Subject Expert, National Technical Expert Group Member, that is NTEP, and a member of Global Burden of Diseases, GBD, Chronic Respiratory Diseases Group. He is a Vice Chair, Academy of Pulmonology and Critical Care Medicine. I hand over to you, Dr. Sanjeev Nair, sir. Lucky to hear from you. Thank you, sir. All yours.
Thank you, Vikas. Are the slides visible?
Yeah.
Yeah.
Absolutely, sir.
Thank you. Yeah. Let me start. Let me start by thanking Dr. Amita Nene, my good friend, and Indian Chest Society for this opportunity to interact with all of you. And let me keep a timer on so that I don't lose track of time here. We're going a bit late. So the job given to me today was to discuss the longer and shorter DRTB regimens, but Dr. Vikas is going to discuss the BPAL regime after me. So I'm limiting my discussion to those regimes which are already there, which are currently there in the TB program in India. The plan for today is that I'll be briefly covering the current scenario with respect to the regimes in India, discuss in brief on how these regimes actually evolved, because that will actually put us in, give us a perspective of how regimes develop. And since, internationally and nationally, there's so much of change occurring in treatment regimes in the recent past and possible in the future as well. So, it's better to know how it actually changes and how it works. We'll look a bit at the science behind the current regimes, particularly the longer regime, how it is designed so that, we know how actually we need to modify it whenever required. Just discuss what are the current regimes, discuss about how we actually find out the right regime for our patients. So with that background, we'll go ahead with the discussion. We all know what resistance is. Dr. Ashok Ratan actually told us about MDR-TB and XDR-TB. MDR-TB basically still remains TB, which is resistant to INH and rifampicin. But when it comes to XDR-TB, sorry, slides? Yeah. XDR-TB, the definition which was there in the past of, resistance to a fluoroquinolone and a second-line injectable no longer applies. Now we have a new definition which talks of a fluoroquinolone resistance. In addition to that, you should have resistance to one of the group A drugs. What the group A drugs are will be coming to very soon, which basically means fluoroquinolone with bedaquiline resistance, or fluoroquinolone with linezolid resistance. Dr. Ashok Ratan actually told us so well on how we diagnose resistance to some of these newer drugs as well. So it needs a whole lot of new technology for us to actually make a diagnosis of XDR-TB today. So if you look at the global scenario, we still, we are the leaders when it comes to TB in a lot of ways. So if you take the total incidence, more than a quarter of the cases are in India. If you take the mortality, again, more than a quarter of the mortality is in India. And if you take MDR-TB as well, more than a quarter of the MDR-TB in the world are in India. Thankfully, we are behind when it comes to HIV-TB, so small mercies. When you look at our national status, however, when it comes to drug-sensitive TB or all TB put together, you can see that the country is doing fairly well. We diagnose more than 86% of all TB. There was a time long back when diagnosing 70% of the TB was considered to be a big achievement. Today, we are actually diagnosing almost 86% of the WHO estimate for our country. But when it comes to drug-resistant TB, as you can see, we still are behind, and we're picking up only, less than 2/3 of our patients. So there's a lot of cases being missed there. Why does this happen? Keeps going. So the country is supposedly moving to something called upfront NAT, which means that the first test that a patient should get access to should be a nucleic acid amplification test. This is what Dr. Ratan was saying, that you should not be actually, still going for smear microscopy. You should be thinking beyond that, and the country has grand plans for that. However, even though in theory that is supposed to be happening, you can see that at country level, still about 77% of TB patients, the first test to which they have access is a smear microscopy. Of course, some states, like the state from where I come, Kerala, it's less, 50%, but still even in Kerala, about 50% of patients, the first test done of is a smear microscopy. However, in my state, the two new technologies, the CBNAT and the TrueNAT, are done in about 50% of the presumptive pulmonary TB for diagnosis. Now, the advantage of this, as Dr. Ethan told us just now, is that when you do these nucleic acid amplification tests, in addition to TB, you also diagnose resistance, that is rifampicin resistance, so that you can make diagnosis of drug-resistant TB early. Now, this is an integrated algorithm, but I'll kind of simplify that further. The right side of the algorithm, which is not really relevant to the topic that we are discussing today. For the other side, what you have is when your nucleic acid amplification test diagnose rifampicin resistance. That is where these regimes that we are discussing today start, and also the regimes that what Vikas is going to discuss later also come from here. So you have rifampicin resistance detected. The next test which has to be done is as per the program, what you're supposed to do is a first-line probe assay and a second-line probe assay, and also MGIT, which was very beautifully described by Dr. Ashok just now. Now, the first-line LPA will tell you about INH and rifampicin and ethionamide resistance. The second-line LPA will tell you about fluoroquinolone and injectable resistance. The MGIT will tell you high-dose fluoroquinolone resistance. It will tell you about linezolid resistance, clofazimine resistance, tell you bedaquiline, delaminate wherever it's being done, and also pyrazinamide wherever it's done. So, you get a whole lot of information based on which you make your regimes. Maybe like 10 years back, I would be speaking to my students and I would be telling them that if I was in the USFA, I would have access to resistance to many of the drugs, and my regimes would be based on a perfect, resistance or sensitivity-based regime. Whereas because I'm in India, I'm unable to do that. But today, being in India, I'm able to do that, and my regime is an individualized regime, which actually, includes the best possible drugs and it's tailored for the resistance pattern this patient has. Of course, what Dr. Rathan described to us earlier is that you can still go further than this, maybe increase the sensitivity of the test. Maybe that is the future, but right now, this is how we approach our patients. Now, designing a regime is not just about knowing the resistance pattern. You need to know a lot more of things. What is the drug resistance pattern in that region? What are the commonly used drugs in that particular region? I go around the country taking classes, and when I went to one particular metro city in India, my usual talk goes by saying that we don't use so much of terazodone in India, so maybe that is not available. But then suddenly somebody raised the hand and I asked, do you have a question? He said, no, I want to make a comment that terazodone is available in my city. This is the name of the brand. This is the cost of the drug. And again, I said something similar about prothionamide not being available that frequently in our country. Again, somebody else raised the hand that I have access to prothionamide. This is the brand I use. This is the cost. So the fact is that every other drug in that in the list that Dr. Rathan actually showed us earlier was being used in that region. And it was not at all to my surprise that region has the highest resistance pattern in India. So you use all kind of drugs and you have all kind of resistance. So that is how it goes. Now, you also need to know what the patient actually used in the past. We call it a drugogram. So you have the period and the drugs used by that patient. You also need to know the resistance pattern in that patient, which actually helps us. And we also need to know other things like comorbidities, contraindication for specific drugs. Suppose the patient has a renal problem, then there are certain drugs you have to avoid. Suppose the patient has a chronic liver disease, you can't give certain drugs, and your regime becomes different. So all those things you need to know, based on which you actually design your regime. So if I summarize how we actually make a regime, what you need to know is a proper history and knowledge of the local factors, as well as for the patient, you need to know the resistance pattern. Your NAT will tell you whether there's rifampicin resistance or not. The LPA will tell you INH, ethionamide, rifampicin, fluoroquinolone and injectable resistance. And your MGIT will tell you whether you have linezolid, moxifloxacin, clofazimine, bedaquiline, delamine, pyrazinamide resistance. So, all these texts put together will help you develop your regime for your patient. If you look at the past, how these regimes actually develop, we should remember that we have been treating MDR-TB in this country under programmatic conditions for the last 17 years or so. It has been a long journey. And when we started, the way WHO looked at the drugs was very different. I mean, the time when we started, just before that, WHO had come out with its guidelines, which used to classify drugs into group 1 to 5. Group 1 are the DSTB drugs that we use currently, and 2, 3, 4 were different, all the other MDR drugs. And the top of the list, the group 2 drugs were actually the injectables, which are supposed to be the most important drugs for treating drug-resistant TB, followed by the fluoroquinolone and other drugs. But by 2016, the whole classification changed. Now the world sort of, more evidence was generated, which suggested that maybe the fluoroquinolones are better than the injectables. So the fluoroquinolones went to the top of the list. Injectables came down. The other drugs also went down. The new drugs like, bedaquiline and delamine actually got included in the list, and we started talking of new regimes and all at this point. What happened further is that that even this got changed. But before we come to that, before 2016, I mean 2007 to 2016, for the first 10 years of our program, the regimes we had were fairly fixed, standardized regimes that we had in our country, which included a short regime. The short regime was not there before that. You had only a longer regime. I think there's a small error on that. MDR regime and XDR regime. I'll skip that slide. Later, a whole lot of new kind of regimes were introduced into the program, all of which actually included an injectable, as you can see in this particular list, unless, of course, there was an injectable resistance. And at one point, we had something like 17 different regimes in this in our program. It was so difficult for all of us clinicians and postgraduates to learn all this. Fortunately, now those things have been standardized, and we have a lesser number of regimes. Now, at that point of time, our issues were that we had very long regimes, a lot of drugs being used, high proportion of adverse effects into these drugs, and patients were really suffering. So because of that, there were high loss to follow-up rates, people were defaulting from treatment, high mortality rates, and overall the treatment outcome was poor. So if you look at the treatment outcome in that period, the early period of our drug-resistant TB treatment, you can see that I have stopped it at, I have hidden the part where we introduced bedaquiline in our regime. You can see at that point of time, our success rate for MDR TB was less than 50%, and that for XDR TB was somewhere around 20 to 30%. So if you just imagine you're going to give a treatment regime of almost 3 years to your patient, and all that you're promising to your patient is a 30% success, I mean, which patient would be happy with that? So that is the reality that we lived in those days. Then the new drugs started coming in, approaches also changed. So, the change in approach has been that earlier we used to think more the drugs in the regime, the better. So you maybe have 6 drugs, 7 drugs in your intensive phase. Nowadays, you are talking of lesser drugs. Maybe 4 drugs are good enough for your intensive phase. And some of the newer regimes, what Vikas is going to tell you now about the BPAL regime, you don't need, some of these regimes do not have a clarity of differentiation between intensive phase and continuation phase. At one point, like I said, the earlier classification, the injectables were the prime drugs. And today we are looking at injection-free regimes. Injectables were a huge crisis for our patients. I'll come to that later. Earlier, we used to believe the longer regimes, and if you give a regime for 2 years, 3 years, 4 years, that was better for the patient. Nowadays, you're looking at regimes of, like 6 months duration for MDR TB, which is again, unimaginable maybe 10 years back, but today that is the reality we are looking at. At that point of time, I showed you the success rate for the country was less than 50%. So some state like Kerala state at one time had 66% success, and we used to pat ourselves on our back that, see, we are doing so well. For MDR TB, we have 66% success. But today, you're looking at aiming for 80, 90% success, even your MDR or XDR TB patient. Some of the regimes that, Vikas will mention will tell you that. So, your expectations and ambitions have gone up a long way. And, earlier we used to keep all the new drugs like bedaquiline and all for our most difficult patients. Today, you want to hit hard with the new drugs and get the best possible outcome for your patient. You used to think earlier that adverse effects are part of MDR management. You can't help it. Today, you want minimal adverse effect to your patient. So the whole paradigm has changed, and you're looking at MDR treatment in a very new, different way. So with that background, when you look at the current regimes, what we have is you have regimes for drug-sensitive TB. You have one regime for INH monopolyresistant TB. You have the MDR regimes, the 2 one, short one, and the long one, which is what I'm going to discuss. And of course, you have other regimes, newer regimes, incoming regimes like the BPAL regime. The point is, today's discussion, we are just limiting ourselves to the longer and shorter regimes. I will not be discussing the others. WHO has reclassified the drugs. Like I said, by 2018, a new classification came in where now drugs are classified as group A, B, C, and A actually includes the best possible drugs like Leoflox or Moxi, Midazolam and Linezolid. Group B actually includes your clofazimine and cycloserine. And Group C has a whole list of drugs, which are the replacement drugs. Our country has reclassified Group C as the order of replacement in our country is different in terms of local resistance pattern. So you start with delamine, amikacin, goes down that way. Why did this change come? This change came because evidence came up. I mean, more evidence is coming with newer drugs like pitomenate, and you have citozolid and new drugs coming in. So it's possible that this could also even change in the near future. Now, the evidence that came out came from an individual patient metadata analysis, which actually told us that the drugs can be classified in terms of efficacy, and the most efficacious drugs were the fluoroquinolones and bedaquiline and linezolid. The least effective drugs, to our surprise, we found that they were kanamycin, paraminous, PAS, and all that. So, in terms of mortality, in terms of death, these drugs were doing very badly. Whereas the drugs like bedaquiline, linezolid, and Leoflox, the fluoroquinolones, are doing extremely well. And again, in terms of side effects, also when they looked at bedaquiline, at that point of time, you were worried about bedaquiline side effects and all. But it turned out that bedaquiline was not as toxic or as dangerous as we thought. In fact, was one of the safer drugs on the list. In fact, the only drug which was worrying for us in this particular list at the bottom is linezolid, which causes a lot of side effects. It's our experience as well. So based on the efficacy of the drugs and the possible side effects, these drugs were classified into group A, B, and C, and that is the classification we saw. Now, based on this, the regimes were designed. So WHO said you need about 4 drugs in your intensive phase and 3 in the continuation phase. So when you need 4 drugs, you take all the drugs in group A, you take all the 3 group A drugs, and then add 1 from group B, and you have a regime with 4 drugs in the intensive phase, and then you stop bedaquiline at 6 months, and then you continue the other drugs, so that you have an adequate regime for you. But then our national experts, in their wisdom, they looked at the regime and said that, okay, linezolid is a drug to which we are anticipating a lot of problems, side effects, and many patients might be stopping that one drug, and you may not have adequate drugs in your regime. So let us start with 5 drugs. You added all the group A and the 2 group B drugs, so that now you have a regime with 5 drugs in the intensive phase and 4 in the continuation phase, where bedaquiline gets stopped at 6 months. Linezolid dose gets reduced because of the anxiety about the side effects, and you have about a 18 to 20 month regime. So this is our traditional longer regime, and this is the logic of developing regime. The thing is, on the right of your screen, you can see that there are replacement drugs. So for example, if this particular patient for some reason is not able to, say they have resistance to fluoroquinolone and cannot take the fluoroquinolone, then what happens is you take the first replacement drug from the right side, which in our case is delaminid, and you add delaminid to the regime. Now, suppose the patient has a QT prolongation, in which case you can't use bedaquiline, you can't use delaminid as well. The first replacement drug cannot be used because of the QT prolongation, in which case you have to go now with amikacin, pyrazinamide, ethionamide. So you go down the list on the replacement drug, and then you make a regime which is actually the best regime for your patient. So based on your various factors that you're discussing, you actually make your regime for the patient, and this is the scientific logic of it. Now, the other regime that we have, the shorter regime, actually developed from a series of studies, or I can't say studies, cohorts in Bangladesh by Ahmad Van Duyn, who was actually a microbiologist, not a clinician, but he developed a lot of regimes in Bangladesh, where he was studying one regime after another. These are all cohort studies. These are not RCTs. So one cohort after cohort was being repeated, and he was changing drugs, trying it out, and finally found that the 6th regime that he developed had good results. So if you look at the results of the regime, if you look at the 6th regime, which is again listed down below, which has kanamycin, gatifloxacin, high-dose INH, clofazimine, prothionamide, ethambutol, pyrazinamide, followed by a continuation phase of gatifloxacin, clofazimine, ethambutol, and pyrazinamide, had a success rate, a relapse-free success rate of 88%, which was quite good in terms of what we actually expect, which was again studied in the study called the Stream 1 study. Now, the point is that, when we looked at the new regime, or how it came about in India or the rest of the world, is that the regime was promising 88% relapse-free success, whereas our regime in India at that time, you could see that it was giving only about 48%. Even the best performing, so-called best performing state of Kerala also had only about a 66% success. So on first sight, this looks like a wonder regime for us, the Bangladesh regime. And the good thing is you're giving it only for 9 months, whereas the other regimes that are on the second line, you're actually giving for 2 years. So it's such a short regime. If you can do 85% success, that was a wonder. But then these were on cohort studies, so they wanted to do proper RCTs, and the stream study came about. So comparing the short regime with the conventional regime. But the surprising thing that came out, of course, the 88% success did not come for the shorter regime, but they got a 78% success. Regime was slightly different because gatifloxacin could not be used. It's not used in many parts of the world. And for prothionamide, the difficulties of procuring were there. So ethionamide was used in that particular regime. But 78% was quite good for a 9-month regime. But to our surprise, what we found is that, the comparator or the conventional regime actually had more than 80% success, which actually gave us a lot of lessons. The reality is that many of our regimes, which do very well in clinical trials, when you roll it out to the field and you put it out in the field, many of these regimes don't do well. Because the problem is not MDR-TB is not just about drugs, not just about designing regimes. It's also about maintaining your patients on treatment, ensuring that they continue treatment, taking care of their comorbidities, taking care of their side effects. It's a big learning experience for us. So at the end of it all, the regime has been evolving also. The shorter regime initially came with the kanamycin, moxifloxacin, ethionamide, and all that. But then, Cana was stopped in programmatic conditions, so then they moved to amikacin. But then soon we actually moved to a fully oral regime with bedaquiline and the other drugs, linezolid, bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high-dose INH, and ethionamide. After stopping, you continue with the continuation phase of levofloxacin, clofazimine, pyrazinamide, and ethambutol. Now, WHO has even further recommended that maybe you can replace the ethionamide with linezolid for 2 months, but that has not come to India. So currently what you have in India is what is there in the middle. So maybe, change can be expected in the future. So the two regimes are there, the longer regime and the shorter regime. So for a clinician, once you're diagnosed rifampicin resistance, your challenge is to decide which regime to give. So I'll make a summary of this. So you have the option rifampicin resistance detected. Like Dr. Ratan said, it could be MDR-TB or could be rifampicin monoresistance. For all practical purposes, we consider all our RIF monoresistance as equivalent to MDR-TB and start them on the MDR-TB regime. So if you have a resistance in the beginning itself, if you can find out whether there can, the INH resistance or a fluoroquinolone, INH-A and a CAT-G resistance occurring together on your LPA or a fluoroquinolone resistance is present, then you cannot give the shorter regime, so you go to the longer regime. There are other contraindications also, which are non-DST based, patient having used the drugs in the past and you don't know the sensitivity pattern, any intolerance to any drug, or the patient having extensive disease, severe extrapulmonary disease, pregnancy, lactation. Bedaquiline is not contraindicated in pregnancy today, but then so there are other drugs in the regime as well. So children below 5 years, even though WHO actually recommends bedaquiline for small children, we still have to get access to these drugs. So if any of the non-DST contraindication or any resistance-based contraindications are there, you immediately jump to the longer regime. If none of them is there, your preferred regime is the shorter regime. So just discuss two cases in brief. So this is an out-and-out MDR-TB patient. I will not describe the case further. Rifampicin resistance detected, first line LPA showing CAT-G resistance but no INH-A resistance, and then fluoroquinolone resistance and injectable resistance not detected. So out and out MDR-TB without any added resistance, no other contraindication, you start the shorter regime. Now the second case, one of our better patients, good patient, doctor, actually had rifampicin resistance detected and also had a fluoroquinolone high dose resistance detected, so that levo and moxi would not be applicable in this patient. Now, this patient has to go to a longer regime, but your traditional longer regime of starting with the levofloxacin will not be effective in this patient. So you have to replace the levofloxacin. So in this patient, the regime becomes bedaquiline, delaminate, linezolid, clofazimine, cycloserine. And now you have to decide on the continuation phase. Do you stop bedaquiline and delaminate at 6 months? So the committee takes a decision whether to give it further for the entire period or not. So the decisions to take. So the long and short of it is that you go to the longer regime, but you need to replace one drug there. Now, you should understand that this situation varies from state to state, region to region. So Dr. Vikas, sitting in Maharashtra, has one of the highest proportion of fluoroquinolone resistance in India. And his city of Mumbai has even more fluoroquinolone resistance. Dr. Ratan's presentation also, he was talking about the high fluoroquinolone resistance in that haystack study. So the point is that certain parts of India, most of the patients will go to a longer regime by default because of the fluoroquinone resistance. Whereas there are other parts of India like Kerala and all, most of our patients go to shorter regimes and they're doing well. There's something called pre-treatment evaluation, which has to be done for all patients. The list of investigations is there. Because I'm running out of time, I'm not going to go into details of it. But the main point is that if you're using bedaquiline, you definitely need to do the serum electrolytes and ECG in all patients, something that you normally do not consider for your TB patients, which is a must-do test. You have liver function test, renal function test, TSH, and so many other tests which have to be done. If you're going for the longer regime, you may also need to go in for other evaluation like ophthal evaluation if you're giving linezolid, the neuro evaluation, psychiatry evaluation may be needed, cardiology evaluation with bedaquiline may be needed. So all these are so there's a list just there in the guideline document, and based on whatever drugs we are using, we do a pre-treatment evaluation. You need to give the patient weight-based dosage, which need to be adjusted if the weight goes up by 5 kg, changes of weight band, and certain other things. Each patient has to be followed up till completion, and the outcome has to be assigned for the patient as per the guidelines. And there is even a provision for post-treatment follow-up for 2 years, which sadly doesn't happen in most cases. So this is the rest of the graph which I showed you earlier. So you see the introduction of bedaquiline suddenly improved the treatment rates. And once you move to the longer, shorter regimes that we discussed just now, the success rates have gone up to 66% and 62% by 2020. So the last cohort that I looked at the TB India report, what you see is that all over India, 68% success for MDR TB and 63% success for XDR TB. It's a far, big improvement as compared to what we had in the past. For XDR TB, you had like 20-30%, which is now at 63%. But you should look at areas of India, like if you look at Kerala, for example, in this table, you can see that MDR TB, we have almost 80% success in Kerala. And XDR TB, that cohort, the numbers were very small, but almost 90% success, which actually means that these drugs and regimes are remarkable and can make a huge difference to your patient. Now, the decision is taken by DRTB committees, which need not be always government committees. Dr. Vikas leads one of the DRTB committees in Mumbai. So you have various committees which actually take decision on what regime to start, how to modify, various other things like when to start NTM treatment. This acts like a medical board, gives you some medical legal safety in case patients have, side effects or any other issues. So I'll conclude by saying that, we really need the technology, as Dr. Ethan was telling us earlier. Technology is available. We need to access technology and ensure that patients do get diagnosed and they get the access to the best regimes, which are bedaquiline containing regimes, obviously, as of now today, with the science that we have. The obvious choice, once you diagnose rifampicin resistance, is to decide between shorter and longer regimes. Very clear differentiation based on exclusion criteria. Preferred regime is the shorter one. If any of the exclusion criteria is there, you go with the longer regime. And of course, the government, the private, everybody has to come together to actually ensure that the best possible treatment is available to our patients. Thank you. Thank you for patient listening, and apologies for saving time a bit. Thank you.
Thank you so much, sir. Sir, for the excellent talk. It is our privilege to listen to you, because you just not only simplified the MDR regime, but also showed us the logic why these regimes are there, especially in India, what is the basis. And it's always been the privilege to listen to you. Thank you so much, sir.
Thank
you. Now, I would like to call Dr. Vikas Oswal, sir. He needs no introduction. Sir is the Chief Chest Consultant, National NTP Trainer, Subcommittee Member, National Technical Expert, CTD, from Mumbai. We all know him, but still I would like to mention a few things about him. He's been pioneer in private-public NGO partnership, motivated almost all the private chest physicians in Mumbai to join and work along with the public sector, and have played a major role in their collaboration with the public sector. He has conducted more than 160 state-level training the trainer all over the India, and more than 150 trainings to all DTOs and MOs in public sectors. He's been credited with various national and international publications. He is awarded for the Service of Humanity by Honorable Mayor Shri Sunil Prabhu. He's contributed in making the national PMDT guidelines for drug-resistant TB, India 2017, 19, 21, and recent guidelines in 23, which will be released in Jan 23. He is credited on as first person to start second-line treatment for DR-TB patients on ambulatory OPD basis under NTEP program in India, and also as the first person to start BDQ and DLM on OPD basis in Maharashtra under the programmatic management. Thank you, sir, for coming.
Thank you for this introduction. Yes, guidelines had already been drafted and prepared. We are just waiting for the release of the new guidelines. Let's hope for the earliest release of these guidelines. Can somebody just switch over to the presentation mode, please?
It's in the presentation mode.
I'm just unable to see the slides over here.
So you can click on slides and then it's already loaded, sir.
Okay. No, I am unable to see the slides. I'm so sorry for this.
So you can click on the slides at the top after the video bridge.
Yeah, I clicked on that. It is showing my own introduction over there.
No, so now it's changed to your slides. Or yours is loaded. Say mbpal_in. You can click on that.
Okay, just
it's already changed. Below ICS TB, you are able to see mbpal, sir. No, below that, there is one more called mbpal, just below that, below ICS. In a gray color tab. So has it changed for you?
Yeah. So I am just able to see the critical DSTB now. And next is, no, I'm unable to see my presentation.
You can just use the site tab to just scroll down. There, your this one is loaded. So mbpal_in_India is loaded.
Oops. I'm sorry. Can I just share my own screen? Let me see.
Sure. So you can start. You can.
Okay. Yeah. Is my screen visible now?
Just give me a minute, sir. Yeah, your screen is visible. Yes.
And is it like on the full mode? Fine.
Not yet. Okay. It's not in the full mode, so it is.
That's fine. Is it is the current slide Zenix trial?
No, it is still in the first slide. SCH mbpal. Can you start moving, sir?
Some technical hitch again over here. It has started moving.
It's I think I'm not sharing, so no, I think it has gone off sharing. Or if you can read out, I can move the slides for you if you're okay with it.
Okay, we'll do that way. No problem. So sorry for this technical hitch over here. Okay, so let's start with the first slide, that is that Zenix trial, right?
Yes.
Yeah.
It's on,
so to evaluate Zenix trial. Yeah. So mbpal basically is nothing but modified BPAL trial. That is the national trial which was being conducted in India. So what is the base of this trial? The base of this trial was nothing but the Zenix trial. Zenix trial was a trial which was being conducted to evaluate the efficacy, the safety and the tolerability of various dosages of the linezolid bedaquiline, and pitomanid. And this drug was been used for 26 long weeks. And just treating TRTB only with 3 drugs was a fantastic game changer, I would say, a revolution which was been brought on this earth, and the need of an hour. As we all know, taking treatment for long 24 months, 18 months won't be sufficient. We need to do something different, especially to improve the compliance part, to reduce the ADR part, and to have a good outcome. Including all these 3, the most important thing was also a relapse. So this 3 drugs, the new drug which is pitomanid, which came into picture, and there was a trial which was conducted using these 3 drugs. So Zenix trial had a phase 3 clinical trial which was successfully conducted in 11 countries across India, that is Georgia, Moldova, Russia, South Africa, and everywhere, all parts of the countries of the earth. So there was a meta-analysis. The data was being gathered from all these sites, and then the study was, the outcome was been given. Next slide. So Zenix and dose ranging of linezolid, there was a different range of linezolid which was in use. The only thing was the linezolid which was in use in Zenix trial was pretty high. They used 1200 milligrams of linezolid, and bedaquiline, the same dose, that is 400 and 200. Linezolid, they used 1200 milligrams for arm 1. There were 4 different arms. And the pitomanid dose which they used was a stat dose for all 4 arms, the single dose for all 4 arms. Go to next slide, please. Various arms. Now, there were 4 arms in Zenix trial, that is arm 1, arm 2, arm 3, arm 4, where arm 1 used around 200 milligrams of linezolid, 23 weeks of linezolid, pitomanid, and bedaquiline was being used. In arm 2, they used 1200 milligrams of linezolid, and followed by 9 weeks. That is, they reduced the dose over there, pitomanid and bedaquiline, whereas 17 weeks of linezolid was 600 milligrams, and pitomanid, bedaquiline was still the same. Whereas arm 3 had 600 milligrams of linezolid for 26 weeks, along with pitomanid and bedaquiline. And arm 4 was 600 milligrams linezolid for 9 weeks and 300 milligrams for 17 weeks. So if you see arm 3 over here and arm 4, they used 600 milligrams, and arm 4 was 600 followed by 300 milligrams of linezolid. So this was the base where was been picked up by our country. And then next slide, please. When the result of Zenix trial was been declared, we had seen a good success rate. That is 91% of success rate was being seen in this arm. That is arm 2, which was that is arm 3, which was having only 600 milligrams of linezolid. If you see the outcome, it was good, 91% of positive outcome, and this became a base of modified BPAL trial in India. So that's the reason it is called as modified, because we never used 1200 milligram or high dose of linezolid. So we reduced the dose of linezolid and made it only to 600 milligrams in arm 1, whereas followed by different arms. We'll be discussing it later. Next slide, please. So MBPAL study came into picture in India. Happy to announce that we were the first one to kickstart this trial in India, and we were the maximum contributors from Mumbai in India for patients which had gone in the cohort of this national trial were from Mumbai itself. So what we did exactly was, there was, next slide please, the sites which were identified in India. These are the 13 sites in India. That is Maharashtra, Uttar Pradesh, Gujarat, Delhi, Madhya Pradesh, Tamil Nadu, Bihar, Delhi, Karnataka. All of them had contributed for this national trial. So there was a certain inclusion exclusion criteria which was been designed for this trial. Next slide, please. The inclusion criteria, the age was 18 to 65 years of age were being included for this trial. Pulmonary pre-XDR-TB cases or XDR-TB cases were included in the cohort list, and MDR-TB failures who were never responding before with the previous second-line drug. So these were the category of patients which were being included for BPAL trial. But LFT should be in normal limit. That was the only inclusion criteria. Plus, it should be a pulmonary case. Add comorbidities of added extrapulmonary cases, maybe pulmonary with pleural effusion, pulmonary with lymph node was still fine. That's okay. But only extrapulmonary cases were excluded from the trial. So if you see the exclusion criteria, which were the patients who were not included in this BPAL trial, basically are, so patients who were being exposed to linezolid before for more than a month, or the patients who were being given bedaquiline for more than a month, were not been included for this trial because this was a trial only for 3 drugs, a shorter regimen, only for 6 months of period. So never used to take a chance. And the severely ill cases, for example, if the patient is having port spine or pericardial effusion or CNS TB, they were not been included under this trial. Next slide, please. So various arms, arm 1, arm 2, arm 3. These were the 3 arms which we used in BPAL trial. When arm 1, 26 weeks altogether, only 3 drugs, that is bedaquiline, pitomidine, linezolid. Linezolid 600 milligrams, no deterioration, no reduction of dosages in first arm. Arm 2 was 9 weeks of bedaquiline, pitomidine and 600 milligram linezolid, followed by next 17 weeks of 300 milligram of linezolid. So there was reduction of linezolid from 600 to 300 for next 17 weeks. And arm 3, where 50-50, that is 13 weeks was been given 600 milligram of linezolid. Next 13 weeks were given 300 milligram linezolid, whereas pitomidine and bedaquiline, the dosages remained the same. Next slide, please. So what were the drug dosages in this? Bedaquiline, as we all know, 100 milligram tablet. So we used to give the same way, that is 2 weeks of loading dose of 400 milligrams, followed by 200 milligrams alternate days for next 24 weeks. Linezolid, 600 milligrams for arm 1, 600 milligrams for arm 2 in first phase, whereas followed by next phase of 300 milligram reduction, and linezolid of 600 milligram for first 13 weeks and followed by 300 milligram for next 13 weeks. Whereas pitomidine 200 milligram tablet, 1 tablet once in a day, that's it. So if you see bedaquiline after 2 weeks, alternate day only, linezolid after few days there were reduction in dose, and pitomidine only 1 single drug. So hardly just 4 drugs to be taken for a period of 6 months. What else we need? Versus 18 months of at least 12 to 13 pills per day, may go to 24 months also. Really, so each and every drug having their own side effects, each and every drug having their own problems, remembering the drugs, uninterrupted treatment for good long 18 months, all these things were being taken care by this regimen only of 3 drugs for total period of 6 months. Next slide, please. So treatment duration, only 26 weeks based upon 2 consecutive negative sputum cultures we needed after 12 weeks of initiation of treatment. If no sputum results were available, 16 weeks, then we used to get a sputum, that is depending upon the culture negativity, we used to call upon the declaration of the patient. So suppose if the patient was basically say sputum culture positive, we need to extend this treatment. This treatment had, and this trial had an extension flexibility of another period of another if there was a sputum culture positive over there. Next slide, please. So detail of MBPAL study in Govandi, that is in our side, what we did was, we will just go through focus on the figures that is on the blue bottom over there. Total 682 patients at our sites were being filtered as pre-XDR-TB patients or MDR-TB failures. Out of them, if you see the 500 next figure, that is number of patients with results of F resistance who were having the results of F resistance, but they were mixtures of PTB, EPTB, seriously ill cases. So out of these 500 patients, 300 were the figures who were being diagnosed as pulmonary cases only, no only EPTB. So EPTB were being filtered out. So out of these, 11 of them were non-responders or intolerance to MDR-TB patients. So even they were being selected for the trial, and 230 of them were being screened. So out of this, at the final figure which we enrolled were 94. That is 42% of our total screened patient of pre-XDR were being enrolled under this trial. So 94 were from Mumbai out of 400 total cohort of national trial of MBPAL in India. So which contributed around approximately some 24% of the patients were from our side for this national trial. Next slide, please. So total number of patients are 94, which were being enrolled for MBPAL trial. So 86 of them had completed their treatment. 3 of them were declared as patients who had completed treatment duration 86. 3 of them had lost to follow-up. We did not. They just left the treatment in between without informing us. 11 of them had missed dosage and had compensation required later on. We had to give them compensation of the drugs. 4 of them, there were, we had a baseline NZ resistance over there. So basically on LPA, we used to filter the patient as pre-XDR TB, and then the culture were being set. Once the DST used to come, if the patient were having added resistance to linezolid or pitomanid, we used to withdraw these cases from the trial. So 4 of them had a baseline linezolid resistance, so we had to even withdraw them from the trial. Next slide, please. So if you see the results, the outcome of the MB-PAL in our side, so total number of 94 patients, out of them 85 have them had completely successfully completed their treatment. 0 deaths from our side. 3 of them lost to follow-up. 4 were failures, declared as failures at the end of the treatment of B-PAL, whereas regimen changed. There is 2 of them needed the regimen change because of the baseline DST. Next slide, please. ADR, out of 94 patients, 11 ADR were SAE, but these SAE, none of them are because of the drugs. We had to mention them as ADR because one of them had fracture, one of them went for delivery, one of them was admitted for some other problem, one had dengue. So there were multiple admissions, but any admissions needed, we had to enroll them under ADR. So ADR per se, because of the drugs, there were 0 ADRs, other than, yes, we had peripheral neuropathies where 2 of them needed a reduction of dosages of linezolid from 600 to 300, but majority of them just completed the treatment with a complete duration of 6 months. So number of SAE which required drug changes, a regimen change completely. So none of them we needed to change the regimen completely. Next slide, please. So these were some of the two of the examples I'm showing over here, which kind of category of patient we used to enroll. So this was one of the patient who was started on B-PAL, that is right-sided lower zone having a big cavity. Where if you see end of 6 months, 182 dosages, the reduction of the cavity has been seen. Whereas the 6 months of stop of the treatment, the follow-up, hardly some fibrotic opacities are seen over there. Next slide, please. This is the second case where a lower zone, a mid zone are showing cavitatory lesions on the right side, as well as some infiltration on the left side also. Whereas end of 6 months showing reduction in the cavity again over here also, and the 10-month follow-up also showed some fibrotic changes over here. So the outcome which we got from MB-PAL, 3 drugs only for 6 months, were fantastic. The only problem was the seriously ill cases. You need to be very much cautious to enroll these seriously ill cases. You need to have a strict follow-up after stopping of the treatment to check for the relapse rate of these cases. It's very important. And especially the ADRs were minimal ADRs for this B-PAL. And we are hoping for this regimen to be rolled out in India very soon. Let's hope for rolling out of the newer guidelines. And once if new guidelines roll up, maybe we would have hands-on and we would be able to replicate this regimen very soon all over India. So this is all about MB-PAL, what we had started. This is modified B-PAL trial, but there is something called as even B-PAL-M. Let us not get confused with B-PAL-M. B-PAL-M is separate from MB-PAL. B-PAL-M is nothing but bedaquiline, pitomanid, linezolid, along with M, that is moxiflox in a regimen. So 4 drugs in a regimen, but this regimen has been used for a MDR TB patient and not for the pre-XDR or XDR or failure of MDRs. So once if the gene expert is showing as RIF resistance, you may just categorize that patient for B-PAL-M, that is 4 drug of regimen. And if the patient is having pre-XDR, just remove the moxiflox from the B-PAL-M regimen, and you can just continue the B-PAL regimen for the cases. Next slide, please. So this was our team where this was our first patient started in India on MB-PAL, that is only bedaquiline, pitomanid, and linezolid. Next slide, please. Last slide, that is B-PAL. The points to be remembered. It has not yet been rolled out in India. We are just waiting for the new guidelines to be rolled out. It was just under national trial, which was conducted by ICMR, and we were one of the sites at Mumbai for ICMR, that is for MB-PAL trial, and having the maximum number of patients. So you need to be very cautious. You need to have your second line LPA in place. You need to have your DST in place. You cannot just go ahead with this regimen without knowing the DSTs of linezolid or bedaquiline. It's very important. Thank you. Thanks for the patient listening, and would be happy to clarify any doubts, if any.
Thank you so much, dear Vikas, for this fantastic and very, very elaborate presentation. Very, very informative. With this, I'd like to start my panel discussion. We've got very, very elite, very, very learned panelists with us, and I'm thrilled to invite and introduce all 3 of them. The first and foremost, our first panelist is Dr. Siva Kumar. He's scientist head bacteriology, ICMR, National Institute for NIRT. And he basically is a principal investigator for many, many trials. He's a part of our program. Amazing qualifications, fantastic work, too many awards and honors from the WHO, from the Australian Award Fellowship, etc. So warm welcome to you, Dr. Siva. We are very, very happy to have you on board.
Thank you, ma'am.
After Dr. Siva, I'd like to introduce Dr. Kinjal Modi, a brilliant and a very bright pulmonologist of Mumbai, a very, very dear friend of mine. TB is his passion, and in addition to being a great pulmonologist, he's a great human being, a fantastic singer, multiple, many publications. He's a governing body member of Indian Association of Oncology and a very, very dear friend of mine. A warm welcome to you, dear Kinjal.
Thank you so much, ma'am. Thank you for the kind words. Thank you, ma'am.
After Dr. Kinjal, I'd like to now introduce the youngest and one of the brightest pulmonologists I know till date. So Dr. Komal Shah, a warm welcome to her. She is a pulmonologist. She's practicing in Nasik. And in addition to doing pulmonology, she's also specialized in infectious diseases. And just recently, her research paper on antibiotic stewardship got her the first prize in our national conference. Extremely energetic, extremely positive, and very, very enthusiastic. So dear Komal, a warm welcome to you.
Thank you so much, ma'am.
So let's quickly start with the panel discussion. I just want to say that we have just so many questions from the audience already. And so I'm just requesting all the panelists that keep the questions very, very crisp and to the point. So the first question I'd like to ask Dr. Siva. So Dr. Siva, I have a question which is very important to us. That, how many bacilli per ml of sample required for the AB smear? Is there any sound coming in the background? Can somebody? Okay, fine. So Dr. Siva, over to you. How many bacilli per ml of sample is required for AB smear to come positive, for AB culture to come positive, for TB NAT to come positive, gene export PCR to come positive?
Thank you for that question, ma'am. So some of the answers have been already given by Dr. Ashok Ratan, sir. To be specific, smear actually it requires at least 10 to the power of 4, that is 10,000 bacilli per ml. And for culture, it varies between 10 to 100 bacilli per ml or 100 CFU, it's called colony forming units per ml. For gene expert, MTB RIF, which is the normal gene expert, not the ultra, it is 131 per CFU per ml. Then for ultra, it is on the lower side. It is around 16 bacilli per ml or CFU per ml. Now, Gene Expert is also coming up with Gene Expert XDR. That is for detection of H resistance and other fluoroquinone aminoglycoside resistance. So the LOD or the minimum bacilli required is around 100 to 131 bacilli per ml. Whereas the local, the Indian make TUNAT has a CFU of around 100, whereas they have also modified something like Ultra. They have TUNAT Plus, which is around 30 per ml. So this is the list of the load which is required for the testing.
Wonderful. I think this is so very important because the thing is, for AB smear to be positive, you require 10,000 bacilli. And therefore, the patient has to have significant TB if you want to diagnose TB just based on smear microscopy. And I'm just so happy that we have genotypic tests now available, which really help us diagnose TB in less than 2 hours, even if it's very, very early TB. And of course, the DST remains, the midget DST remains the gold standard. Wonderful. With this, I'd like to go to Dr. Kinjal. Although Dr. Sanjeev has already told us, I think it's a very important question. So let's just have it repeated from you. So what are the indications and contraindications of shorter MDR TB regime?
Sure, madam. At the onset, I would like to thank Dr. Amita Nene, madam, as well as ICS for having me here as a part of this panel discussion. It's a very relevant question, madam, and it needs to be hammered each and every time when we do practice MDR TB. There is very simple thing that Dr. Sanjeev has put very nicely, that two and longer. Shorter regime, basically treatment can be completed earlier, and Dr. Vikas has given us a more shorter regime. Basically, it is also possible, but that is still under trial, so we are not having at present in our program. So, as was been discussed, 4 to 6 months of bedaquiline with clofazimine, levoflox, parazenamide, ethambutol, high-dose INH, ethionamide, followed by 5 months of levofloxacin, parazenamide, ethambutol, and clofazimine. So that was the basic regimen. Now, I should know very clearly when to not to give. Simple to understand. For patient should be MDR or RR diagnosis at number 1, but should not have H resistance, which is LPA showing INH-A and CATG both. So if either of them are positive, it is okay. But if both are resistant, then basically we cannot give a high dose INH in that patient. That is why this shorter regime would be applicable. One more thing, we don't want any monoclonal resistance at all in this shorter regimen. So very clear, 3 points: H resistance, either INH-A or CATG, not both. Monoclonal resistance should not be there. And obviously we are treating MDR, so R resistance should be definitely be there. Now, coming to other things, other inclusion criteria can be not very extensive TB, not very severe extrapulmonary TB, children who are above the age of 5 years of age, and people who are not pregnant, and females who are not pregnant and not lactating. So these are the inclusion. Other way around is exclusion criteria. Just to cover up those things, children less than 5 years of age, basically if a DST, if showing any resistance to any of the drugs which are going on over here, then we cannot give. So definitely that has to be excluded from the shorter regimen. The patient has to be excluded from the shorter regimen criteria, even if it's started. Drug resistance, if it is there, for bedaquiline, especially if the patient is in unstable, what we call arrhythmias, and that kind of patient should not be taken for this kind of regimen at all. Very severe pulmonary TB, basically it's bilateral disease. So just to understand, they have not specified a less pulmonary disease inclusion, but exclusion criteria, bilateral cavity disease, better not to go for a shorter regime, go for longer regime. Next is extensive, what we call extrapulmonary TB, that is generally a meningitis or a CNS TB. Lymphadenopathy definitely can be given a shorter regime, no issues with respect to that. And patient not exposed, patient if they are exposed to either of the second-line drugs for more than 1 month, then they should not be given shorter regimen at all. In less than 1 month, definitely they can go ahead. This is a nutshell inclusion exclusion criteria for shorter regimen.
Great. So Dr. Sanjeev had clearly told us, and I'm very happy that Dr. Kinjal has also repeated these for us. So we need to remember these criteria. We need to understand that shorter bedaquiline regime is for people who have less TB. It is not for people who have extensive TB. It is not for pregnant women. It's not for children who are less than 5 years of age. So if the patient has CNS TB, miliary TB, you rather give the longer bedaquiline regime. So now coming to Dr. Komal. So again, Dr. Sanjeev Nair has told us, but coming to longer bedaquiline, please tell me what are the indications and contraindications of longer bedaquiline regime?
Thank you so much, ma'am, for inviting me to this talk. And this question has been already answered in my previous question. So basically, when we are treating the drug-resistant TB, either we are giving shorter or longer for now. So when we are not able to give shorter regime to a patient, we offer them the longer regime. That is the indication. Again, I don't need to repeat that. It is on the DST basis when we have INH and CATG both mutations, or fluoroquinolone and second-line LP second-line mutation, or in cases when children less than 5 years of age, pregnant and lactating women, or when there is already patient has taken more than 1 month of second-line treatment, and we do not know the sensitivity pattern in those patients, or if the patient is not able to tolerate any of the medicines, if there is any toxicity, or we need to replace even one drug in the shorter, we have to put the patient on the longer regime. That are the indications for longer. However, there are no contraindications for it is a very flexible regime. Though we have the given 5-drug regime for Indian guidelines, but we can modify, individualize the regime as per the patient's requirement. If the patient has renal failure or hepatic failure or cannot tolerate any of the medicine, we can adjust the other anti-TB drugs as per the group A, B, C, and as per the priority list which is given, like dilaminate, then amikacin, then further drugs, we can replace the medicines and continue with the longer regime.
Wonderful, Komal. So this was a fantastic answer. So I just want everybody to know that the longer regime is more flexible. So of course, if the patient is not in the shorter regime, you can't give it. But as such, longer regime does not have any contraindications because you have so much flexibility to introduce another drug in place of a drug that the patient may not be able to take because of either side effect or because of resistance patterns. So this was great. Now I'd like to come to Dr. Ashok. So a very interesting question everybody wants to know. So if you can just tell us in short, what are the reasons for discrepancies between phenotypic DST and genotypic drug resistance tests, whereby the medicine is sensitive on phenotypic, but the same resistance is seen in genotypic? What are the reasons for this?
There are several reasons which could account for this. One reason would be that if the phenotypic susceptibility is not done quickly, if you keep on subculturing the isolate, then what happens is that the slow-growing bacteria get left behind, and the bacteria which are susceptible grow faster. They would then give you a false susceptible reaction. The second one is that there could be a heteroresistance. If in the initial stage, there is a mixture of some isolates being resistant and some being sensitive, susceptible. So if you do at that time, then you can get a discrepant result. Then there is There was a study which was done in Latvia, where they took 63 MDR strains and then did next generation sequencing to be the gold standard. And after that, they compared phenotypic DST with genotypic drug resistant testing. And they found that there was 100% correlation with INH and rifampicin and linezolid. There was more than 90% concordance with in Oflox, pyrazinamide, and streptomycin. But there was poor correlation with ethinomide, ethambutol, moxiflox, amikacin, and kanamycin, where there were mutation in the target genes, but the phenotypic was sensitive. On the other hand, capreomycin has phenotypic resistance, but genotypically there was no mutation. So that would mean that we still have to understand more about the mechanism of resistance.
Very well said, Dr. Ratan. I totally agree with you. Just to make it a little simpler for us pulmonologists, because you microbiologists have so much more awareness of these terms. So I just want to tell our pulmonologist, Dr. Ashok Ratan, very, very nicely told us that the thing is that very often you have silent mutations which actually don't confer actual drug resistance, but the genotypic tests will pick them up. So very often the patient has a silent mutation, and therefore the LPA or pyrosequencing or GeneXpert XDR may show resistance, but because it's a silent mutation, therefore phenotypic correctly will show sensitivity. Sometimes you might be having heteroresistance, in which case the larger population, which is more than 65%, will be picked up, and therefore you'll just see one population. So so this was great. Thank you so much.
There's just one more point.
Yes.
There's just one more point. In rifampicin, the rifampicin itself is about 1193 amino acids, but you're detecting a region which is amplifying 81 base pair, which is the hotspot for rifampicin resistance. So if 96% of mutations occur in this hotspot, and they will be picked up. But if the mutation is there outside this hotspot, which is happening very frequently in Africa now, then those will be phenotypically resistant, but genotypically you would say there's no mutation, because you are looking at mutation with Gene Expert. You're looking at mutation only in the hotspot. That is
Correct.
what is normally happening.
Yes, very well said. So basically, the thing is, for genotypic test, we don't know all the mutations. So whichever mutations know, we are picking up. But if there is a mutation which is outside what is detected by genotypic, then genotypic will falsely show it to be susceptible, means the resistance not seen. But phenotypic will show us resistance, and therefore always get phenotypic DST done. You have to make sure that midget DST is done every time, despite you have genotypic results available with you. Thank you, Dr. Ratan, for this point. I'd like to now come to my dear friend, Dr. Sanjeev Nair. Thank you for your fantastic talk. I want to ask you, what is treatment evaluation and what is its significance?
Thank you, Dr. Amita. Am I audible?
Yes, yes.
Yeah.
Thank you. So, very important question. I did talk about it in the presentation, but then, just again to re-emphasize on that, the drugs that we give in MDR TB are all very, probably, toxic drugs, if I can call them that, which have potential for large number of side effects. And before we start these drugs, we really need to know whether the patient taking the drugs would have any issue with those drugs. So we do something called pre-treatment evaluation, which is like I described in my slides, based on which all drugs you use or which regime you use, might vary from regime to regime, from drug to drug. So one of the questions that came up in the box today is, how do you deal with a patient who has chronic liver disease? But then in the first place, we need to know that the patient has chronic liver disease. So, in the beginning, the pre-treatment evaluation would cover a liver function test, a renal function test, ECG, electrolyte, and all that. So in that, if I come back to that question that was asked in the chat box, so if this patient has a chronic liver disease, your pre-treatment evaluation will pick it up. Now, once the pre-treatment evaluation has picked up a chronic liver disease, the patient cannot get hepatotoxic drugs, particularly if his liver disease is far advanced. So in that case, you're not able to use high-dose INH, you're not able to use ethionamide, you're not able to use pyrazinamide. So your patient obviously goes out of the short-term
evaluation. We'll take the audience questions later. Just tell us once again about treatment evaluation.
Yeah, so the pre-treatment evaluation actually helps you to find out that this patient cannot go into a shorter regime and the patient goes to a longer regime. So your pre-treatment evaluation covers all such investigations, which actually helps you decide which all drugs can be taken to the patient, helps you to anticipate what side effects you can have for your patient. And if you have your pre-treatment evaluation shows that the patient is pregnant, then again that leads to a change in the regime. If it actually shows that the QT segment is prolonged, you need to change certain drugs. And also in terms of dosage that you can give. For example, if your pre-treatment evaluation shows that the patient has a chronic renal disease, you need to modify the drug dosage. So your pre-treatment evaluation basically helps you to kind of decide regimes, helps you to predict what side effects could actually occur in a patient, which could lead to more close monitoring of these patients. And also helps you to give the right dose and the right regime for the patient. Extremely essential. The treatment evaluation has to be done for every patient. How it is done varies from region to region. So Dr. Vikas was telling you about ambulatory care. So way back in 2007, 2008, when we started our program in Kerala, all our patients underwent pre-treatment evaluation as ambulatory patients, whereas in many other parts of India, they were admitted and then the pre-treatment evaluation. The program aims that all the pre-treatment evaluation investigations should be done free of cost to patients. The patient should not be forced to spend any money on that. So again, that also varies from part to part. I hope, Amita, I answered your question.
No, wonderfully said. I really feel that you made this very, very important. The pre-op evaluation tells us that patient has a few existing problems and therefore certain medicines should not be used upfront, which I feel is something very, very good, because we are not doing this for sensitive TB. So I feel this is a fantastic step. And as Dr. Sanjeev rightly said, it's very good that the patients don't have to pay for it and it's being done free of charge for the patients. And we must make sure we do pre-op evaluation first before writing up a regime of our choice. Thank you, Dr. Sanjeev, for this answer. And we are going to again ask you a little later more questions for you to elaborate on difficult regimes. I'd like to come to Dr. Vikas. So, Dr. Vikas, you spoke wonderfully about the VPAL regime and the MBPAL. So, I want to once again ask you, what is MBPAL regime? Can all the patients be selected for MBPAL or only selected ones? Please elaborate.
Okay. So, just to clarify some more thing over here, MBPAL and BPAL-M MBPAL is nothing but modified BPAL trial, the trial for all pre-XDRs, MDR TB failures, and XDR TB patients. And BPAL M is bedaquiline, pitomine, linezolid with moxifloxacin only for MDR TB patients. Now, a shorter regimen, only 3 and 4 drugs for 6 months of period, that's it. Selection of patients, very important. First thing, not rolled out in India yet. It is yet under a trial process in India. Very soon, it's going to get rolled out within the rolling out of the upcoming of the new guidelines. It is still in pipeline. So if the patients to be selected, which one I do select? So the moment you have a RIF resistance, think of BPAL M. If it is RIF resistance, think of BPAL with moxifloxacin. If your FQ are sensitive, the moment if you have a report of linezolid resistance or FQ resistance, no shorter regimen, you will have to switch to the all longer regimens as per the criteria which Dr. Sanjeev Nair has already explained. Secondly, for MBPAL, hemoglobin should not be less than 9. The patient should not be seriously ill. Patient should not be pregnant. The HIV in HIV patients, CD4 count, the cell count of less than 50 cells per microliters not allowed for giving this shorter regimens. Then comes the patient who has been exposed to linezolid and bedaquiline for more than 2 weeks. Do not take them for this shorter regimens because unnecessarily we don't know whether the patient has been given with the right combination of drugs or no, or whether this patient would be in a pre-resistance phase. We don't want any sort of problem since it's a very short regimen. Most importantly, you need to keep a thorough follow-up even after stopping that regimen after 6 months. That's very important.
Okay, fine, great. So basically, the patient cannot be very, very sick if you want to use BPAL, and you cannot be resistant to either quinolones or linezolid, and hemoglobin has to be 9 and more. Great, wonderful.
Resistance is fine for giving a modified BPAL, that is bedaquiline and linezolid, but not for BPAL M. That's it.
Because using moxifloxacin. Absolutely, yes.
Right.
Okay, I'd like to now come to Dr. Siva. So basically, we know midget liquid culture is the current gold standard for AFB culture and DST. So do we need to get solid media, LJ medium culture done anymore? And why?
So if you see in the National TB Elimination Program, we have around more than 50 laboratories which are doing culture and DST, and most of them, not most of them, all of them have liquid culture, and hardly anyone does solid culture. But then, so for diagnosis as such, we use only midget culture and midget DST. But then solid culture, can we give away? It's a debate again, depending upon whether the time requirement is more important or accurate diagnosis is more important. For some of the samples, like which are very, it's not that we can give away midget and give away solid and move to midget, but then we can, along with midget, we can add on solid culture to get a better yield of diagnosis. So for us, we use solid culture for extrapulmonary samples. So now for that, we add liquid culture as well as solid culture so that we get maximum out of it. But then if you want to replace that, then you should have more midget cultures, like more than 1 or 2 midget culture. Instead, we use solid culture. So that is one use of it. But then we need to have a good capacity for it as well. Otherwise, midget culture is taking care of everything. DST, no. Most of the DSTs have been faster with midget, so that is the best method to do. Another thing which I want to reiterate here is if you want to do a database development like what Dr. Ashok Ratan had showed on database development for mutational catalog, which we have developed from ICMR and NIRT. So those kind of research activities, those kind of database development and surveillance, solid culture will be more appropriate, because then you will have enough culture to do other tests and discrepancy resolution when you're doing both phenotypic, genotypic test, and then comparing it, then saying this particular mutation is responsible for drug resistance. So that's the position of solid cultures. Thank you.
So, I agree with you. I had one extra point to make. I basically feel that any good lab, any tertiary care center, even in today's day and age, has to have solid LJ medium. I mean, it's a different thing that people may not have, but there is a very important reason for it. And every good lab will always have midget in addition to LJ. And this is because whenever you use midget culture alone, that time all the organisms which are, if the patient is double population, then the organisms which are in predominance will grow first in midget. And then you'll subject to sensitivity, and the slow growers will be completely missed out. And the slow growers will be picked up only in LJ medium. So the thing is that if you have double population, so if patient have extensive cavitary disease, or if the patient has taken irregular treatment, or patient has taken treatment and then had a relapse, in these cases, solid media only will tell us if there's double population. So I want to say that even in today's day and age where we say that midget is the gold standard, we cannot just give up solid LJ. We have to put it in midget, and we have to put the sample also in solid LJ growth. Am I correct? I mean, would you agree, Dr. Siva? Because
Yeah,
Dr. Kamil always tells that, and even in our Bombay hospital, I mean, the same sample goes for both. It goes for midget also in LJ, and therefore I want every microbiologist and pulmonologist, because some people may be in smaller centers. So you have to make sure that microbiologist is using both midget and LJ, because if your patient is double population, you will not find out about this. So great, thank you. I'd like to come to Kinjal. Dr. Kinjal, I'd like to ask you this question. What common instructions should we give to our patients before starting MDR TB treatment in general to avoid complications? Just in short, what are the instructions? 1, 2, 3, 4, 5.
Yes, ma'am. Thank you. Counseling is a major part of the treatment of TB. Just to start with, madam. Basically, in short, I want to cover only few points. First and foremost, always counsel the patient along with the family together. Tell them it is a phase of life, a bad phase of life. You have to all fight together, and together you can. Explain the diagnosis of the whole part, because many times MDR TB is very ignorant. Patients are very ignorant about MDR, because types of MDR TBs. Investigation part, as Dr. Nair already told, pre-treatment investigations. During monitoring, we require various investigations. So patients need to come to for follow-up very frequently for all investigations. ECGs, when we have a bedaquiline-based regimen, all those things are definitely there. Now come to the ADR part of it. So ADR, we know that second of ADRs can count like any the number of them. Simple line, any problems you have, please report back to us. That's the only thing we can tell you in short. Else, if you can take a lecture on ADRs, it can be seminar by itself. One more thing is some tips about contraception also in young females. This definitely has been told to them to avoid pregnancy. Next is we have to prevent the worsening of the disease. So whatever best they can do with a good compliance, that is also part of counseling. And last but not the least, counseling is a continuous process. It cannot be one day thing. You have to be involved with the patient throughout the treatment schedule, so that everything and every small queries of patient is answered in that. Thank you so much, ma'am.
No, wonderfully put. I just like 2, 3 points which was so importantly reiterated by you, which are taken for granted, that we have to tell them that you need to be regular. You always need to make sure family is there, and you need to make sure that you advise about contraception to women, because you don't want them to get pregnant. And of course, you want to warn them about important side effects. We always want to tell them that if your vision gets affected, immediately come to us. If you start tingling or you get some kind of reduced sensations in your feet, then do come back to us. If you start vomiting, do come back to us. So common side effects also we want to warn them from before, so they come. So thank you, Kinjal. This was a fantastic answer. And now I would like to come to Dr. Komal. So Komal, basically LPA is something which is very, very important. We have first line and second line LPA. So can you tell me that what mutations do first and second line LPA tell us? And what are the advantages and disadvantages of LPA?
Thank you, ma'am, for the question. So basically, LPA uses PCR and reverse hybridization method to detect the mutations. Now, first line LPA detects RPOB, CATG, and INHA gene mutation. So we can know about the rifampicin and INH resistance. And second line LPA detects fluoroquinolones and second line injectable mutations. Now, coming to the second part of the question, that is advantage and disadvantage. Basically, it is a very, we can get the results in 1 to 3 days. It is very sensitive and specific. If we talk about rifampicin, the sensitivity is 97%, specificity is 98%. So highly sensitive and specific, we can start the regime based on this this sensitivity pattern. So it is extremely useful. However, there are some disadvantages, like it cannot be used as point of care test. We need to have laboratories, equipments, we need to have trained personnel, then quality control should be there, biosafety panels should be there. It is expensive, we need to have manpower. And as Sir mentioned earlier, it cannot replace cultures. We must have the phenotypic also detection as well. So that those are the disadvantages. I hope I'm not missing out on any other point.
So wonderful, like you said, first line tells about HNR. It also tells us about ethionamide and high dose INH.
Ethionamide, yes.
And the second line LPA, in addition to quinolones and aminoglycosides, second line injectable aminoglycosides, it also tells us about high dose quinolones, high dose moxifloxacin resistance. So this is very, very important. And as Dr. Kumar said, the problem is that it requires a good setup. It can't be done everywhere. Also, to read it, a lot of expertise is required because it's all about bands. So how well you're seeing the bands. So that is important. And the other one is that it tells you about double population, one of the only genotypic tests which tells you about the presence of double population. Dr. Sivakumar has actually raised his hand, so I'm sure he's got fantastic points to make. Dr. Siva, can you please add on to what we are missing, please? Dr. Siva, have you raised your hand?
Yeah. So the disadvantage, what I would like to point out is it has to be done on smear positive samples. Smear negative sample doesn't answer most of the so that is a major disadvantage. We need again 10 to the power of 4 bacilli or 10,000 bacilli to get a good results. Around 10 to 20% of the samples, don't answer LPA.
Correct. So just a question, basically, because actually genotypic molecular diagnostics is my passion and it's my forte. So I've done a lot of work in that original research. So basically the thing is that the LPA, we have the version 2. So LPA version 2 is actually working well with AB smear negative samples also quite well. So we have somehow found that, so we basically always subject if AB smear is negative, but if the CB NAT is going to work out, then in that case, if the CB NAT works out, then we are getting LPA done. It is giving us the result. So I think we could try. What do you think, Dr. Siva? If it doesn't work, it's okay, but could we try?
Yeah. Trying is not a problem. So when we looked at, we couldn't quantify the CFUs in GeneXpert, but when we did the same thing with TrueNat, we see that if we have 10 to the power of 3 bacilli and below, that is 1,000 and below, it didn't work. But when it has 10,000 and above, it works.
Yeah, I just have to add over here. As ma'am rightly said over here, with the version 2.0, definitely the LPAs would give you results, but not always positive. But yes, 50% time it will give you results. The problem with the public sector is we cannot wait for the 50% result to come. So that's the reason we don't directly send the samples for LPA. And in public sector, we just focus more on the bacillary load of high and medium, and then we send for LPA. Whereas in private sector, if you see, you can just send for LPA, they won't charge you. If it's negative, they'll refund you back. That's the thing. So once the culture is positive, you can get a LPA or DST from the positive isolates. It's okay. But version 2.0 definitely don't need a positive sample for you to give results.
Even in the kit they are writing that can be done. It's officially written in the kit. It can be done on smear negative sample. And the other thing is, though WHO said that LPA requires 10,000 CFU to work out, we have basically seen that it's working out also with 300 to 400. So I just feel that, but the problem of
50%.
What we need to notice here is that this is not a diagnostic test, but for DST alone. That means you have to make a diagnosis first, and then this is the second test. And we took part in a study for JEET. There were 18,000 tests which were done, and not one was requested for LPA. So the algorithm is clear, but I think it's more for discussion rather than for on-field. So if you look at, if your lab is doing both diagnosis as well as LPA, then it's good for the patient. But if you're sending out diagnosis and then you're getting a second test done, then normally it's not being done. So that means that is why we have generated MDR by using Gene Expert and taking rifampicin as a surrogate marker for MDR, which it is not. So
Okay,
we've been making a mistake for the last 10 years.
Okay, I think let's not get into this. Let's go on with we have just so many questions, but point very well taken. I like what Dr. Siva said, that, in the program, it is not easy to roll it out to everybody. I completely agree with him.
Yep.
And also one of the problems is that in peripheries, the results are coming only after 2 weeks. So that is a problem. And I completely agree with Dr. Vikas, because both of us are practicing in the same city and we do the same thing. And we have seen that even if AV smear is negative, our LP is always working out. And what Dr. Ashok was also saying is correct. So I agree with everything. But with this, I'm going to move on to some very interesting question, Dr. Ratan. So what if AFB smear, this is something very, very clinical. So what if AFB smear is positive, but AFB culture comes negative? What are the implications? That is number one. And what if the other way around? That patient's AFB, patient's AFB smear is positive, so we'll expect the culture to be positive. But if the AFB smear is positive but culture is negative, then how do you explain this in a patient who's not on treatment and a patient who's on treatment?
So let's take the first condition, where the patient is on AKT and smear is positive, culture is negative. One is, if it is an initial sample, then it could be that it's a false positive, and patient did not have TB, right? Second one is, if you have taken after the patient has been on AKT for some time and you're taken as treatment, then that means that the patient has smear positive but culture is negative. That means the patient is improving and the patient is responding. So you continue with the symptom.
Right. Yes.
The second one is, then the second condition is when the patient is not on AKT and you detect smear positive but not culture positive. We need to understand that not every AFB is Mycobacterium tuberculosis. There are 172 Mycobacterium. There's Mycobacterium in water, there's Mycobacterium in butter, there's Mycobacterium in grass, there's Mycobacterium in smegma. So Mycobacterium, they all look alike. And so on smear, AFB is not equivalent to Mycobacterium tuberculosis.
Wonderful.
So that means we should then look at the clinical condition, look at the X-ray, look at the totality, and not look at only smear.
Okay, great. Dr. Vikas had raised his hand. You want to say something, Vikas?
Yeah, so AFB smear positive, and if the same sample Gene Expert is negative, probably I would also interpret it as maybe suspected as NTM over there.
This is not
I would definitely say,
because we're saying culture policy. We were discussing culture only. If it is, if Gene Expert is negative, then you should think of Mycobacterium other than tuberculosis.
Correct. Yes.
yeah.
Yes, Vikas, point very well taken, but the question was a little different, that if AV smear is positive and if the AV culture is negative. So, Dr.
Culture is
Ashok.
negative. Okay.
Yes. So, I agree with Dr. Ashok. If AV smear is positive and the patient is on treatment and the culture comes negative, then probably the patient is responding. These are dead bacilli. I just want to say that very often it could be happening that patient has never taken treatment before. Patient actually has TB because AV smear is positive and even CB NAT shows MTB detected. But if the culture comes negative, then please check, because there's a decontamination process which is involved before the culture is started. And there are certain labs, they may be over decontaminating. So if the lab over decontaminates the sample, then though the patient is actually active TB, the culture comes negative. So if you're facing this situation with your lab whereby patient is active TB and it is TB, and if the culture is coming negative, then please talk to your microbiologist. Maybe over decontamination is our problem. So I think this was a clinically important point which may help us in our practice. So thank you.
In that, let me just add that normally in the lab they suggest that you should get 5% contamination. If you
Correct.
do not get 5% contamination, that means you're killing, you're using very harsh Petros method. And as a consequence of the Petros method, you're killing the few bacteria which might be there and not being able to detect by culture. So in
Yeah.
that case, WHO has now added that you do CRP. See, along with the 4 drug, that means you're doing to find out what is the significance of smear positive and culture negative. You first see whether the 4 symptoms are there, and then you also do CRP. If the CRP is raised, then you should get the X-ray done, and there's CAD available, computer assisted diagnostics, which you look at hotspots in the lungs. That will help you in saying whether the patient has something or not to be done. No, or the patient is.
I'll just we'll straight away do a CT scan. We won't do so much, Anyway, but thank you. Interesting point. But since we are practicing, now coming to my friend Dr. Sanjeev, who's doing fantastic work in Kerala in TB. So, what if the patient has treatment failure? So, what do you do? How do you tackle it? You've given the MDR regime, and so when do you say that the patient has failed treatment? If the patient has treatment failure, how will you tackle it?
Yeah, I think with a very interesting question, because traditionally we have been defining failure as microbiological failure. We look at the culture results and declare it. But of late, of course, WHO has changed the definition of failure. So if you stop a regime completely due to whatever the reason, and then you're starting a new regime, it is called failure. So I think the definition of failure has changed now from what we traditionally believe. I assume that you're talking of microbiological failure where the culture is positive beyond in the last 12 months of treatment, where it should be either can be a patient who was culture converted and then reverted to culture positive later, or it could be a patient who failed to convert and remains positive towards the last 12 months of treatment. So in that case, you declare failure in the patient, and now you have to tailor a new regime for the patient. At whatever point the patient remains culture positive during the treatment, could be even from starting at 3 months, 4 months, you do the culture. Whatever the culture comes positive, it is remaining positive. At that time itself, we will look for amplification of resistance. We are looking for whether the patient has developed added resistance to any of the other drugs where patient was not previously having resistance. And then you also look at, at the point of failure, you go through the entire diagnostic algorithm. You look at the entire battery of tests. You look at, why the patient actually failed. Is there amplification of resistance and all that? And now if you can find out a new resistance pattern, your regime will be based on that. Modification of regime we already discussed, so I'll not repeat it again. So that is done. Of course, in some of our patients, we may not be able to find out why the patient actually failed. The sensitivity pattern may be the same, or, the patient may not actually... so in that case, we go further and we even do a whole genome sequencing. We look at other mutations which might have been missed by our traditional tests. If the previous diagnosis was based purely on molecular tests, we might go to a phenotypic testing to look at whether the molecular test, because even with the high sensitivity of rifampicin for your gene expert, is still 95%. So still 5% can be missed. So we look at all the other tests, and then we also look for of course, I should have said that first. The first thing, of course, we should be looking at is whether the patient actually was taking the drugs, because many of the patients who claim to be taking drugs are not compliant. So you look at the drug compliance. And then we also look at therapeutic blood level monitoring. We look at the blood levels in these people who have failed if we are not able to find amplification of resistance. And then we look at whether we need to modify for that.
Wonderful.
So, Dr. Amita, thank you for your excellent discussion. I need to leave at this point. I hope that you will excuse me and you will continue with the excellent discussion. Thank you.
It's already 10:30. In fact, we have 42 questions in the audience link. We will miss your presence, but thank you so much for fantastic inputs. We so appreciate.
Thank you it was an excellent meeting. I'm sure that you will be discussing further. Thank you so much.
Thank you. Thank you. So I really liked what Dr. Sanjeev Nair said, that if there is treatment failure and if you find that the patient's sensitivity is still the same, then please make sure that the patient was compliant in taking medicines, because in today's day and age also, we actually have patients who are throwing away their tablets and not taking them, So compliance and therapeutic drug monitoring is very, very important. And if we can do whole genome sequencing, it'll be fantastic. So great. After this, I'd like to come to Vikas, my friend. Vikas, so, peripheral neuropathy is a major, major side effect when patients are on second-line AKT. So can you tell me the names of the medicines amongst all the AKT which cause peripheral neuropathy, and how would you treat peripheral neuropathy in patients who get it because of AKT?
So nowadays it is very commonly been seen with majority of our patients, peripheral neuropathy, especially when the patients are on second-line drugs for more than 4 months onwards. The drugs causing peripheral neuropathy, we all know that high-dose INH was a drug, or the INH itself was a drug which used to cause peripheral neuropathy. Earlier also we used to see in first-line drugs also. In second-line drugs, there's one more drug, the major culprit, that is linezolid, which is the major culprit drug for causing peripheral neuropathy. And also if you see leoflox, and leoflox is also third drug in the category which may cause peripheral neuropathy. So these are the 3 drugs. But trust me for this, if your patient is on high-dose INH and if he's on short-course regimen, please do not just stop the INH and continue rest other drugs or replace just one drug. No, shift the patient on all-longer regimen without linezolid. You can do that. Second, if the patient is on linezolid-based regimen, then please reduce the dose of the linezolid to 300, but grade the neuropathy. That is very important. It is grade 1, grade 2, grade 3, grade 4. If the patient just comes to you with a complaint of just tingling sensation, numbness, that means the initiation of the peripheral neuropathy, get an NCV done, grade the neuropathy. That is very important. If the grade is 3 or 4, do not even dare to continue linezolid even with the 300 milligram. Please stop the drug over there itself. Replace the drug with some other working drug as per the LPA or DST. That is very important. Do not re-challenge linezolid at all like we do in other cases of hepatotoxicities or anything. Do not re-challenge linezolid. Do not start. Just replace it, linezolid. Do not even dare to start that. Because if the peripheral neuropathy goes to grade 4, sometimes it may become irreversible. But trust me, ma'am, in my cohort of more than 10,000 DRTB cases, 100% of them have got cured with completely all right with peripheral neuropathy. That's really true, because timely stopping of the drug is very important. Add pregabalins or gabapentin, gabapentins. That is very fantastic drug. Can be given for month, 2 months, even 3 months. But do not expect the improvement to start immediately within second day or third day. You have to counsel your patient. You will see the improvement or the changes 3 weeks later, starting of the drugs of pregabalins and gabapentins. More preferable for me, more than pregabalin, gabapentins have given me a fantastic outcome and the results. You can escalate your drugs of gabapentin from 100 to 200, 200 to 300, 300 to even 400 if required as per the grade. You can add some of the amytalins, that is one of the anti-anxiolytic drug which we use very commonly, but do not give more than 10 milligram or maximum 25 milligram. 10 milligram is sufficient enough, adding along with gabapentins. Third, that is, if you give tryptamers or amytalins more than 25 milligram, you have to take care of the QTC prolongation. That is very important, because that will cause QTC prolongation along with the bedaquiline or delaminate. Third, suppose if the patient is not responding to gabapentins, gabaneurons of say 200 or 300 milligrams, even additional of amytalins you have added, now that means the patient do require addition of a drug, that is duloxetine, will give you a third drug which will give you a very good improvement for your patient. And trust me, 20 milligram twice in a day or even 3 times in a day for 30 days or even 60 days will definitely take care of entire neuropathy. Patient will be all right. But please do not start linezolid at all. Third, even after giving all these major drugs, counseling, 1 month pass, patient still not improving. Now the time linezolid or leoflox also need to be either changed if required. You will have to take that decision also sometimes. So you have to closely monitor your patient. NCV to be done for medical legal purpose. Otherwise, I don't find any difference for NCV. I just need for grading the patient, which I can grade it clinically nowadays.
Okay, wonderful. So, Vikas, great information. I just want to quickly summarize that all the AKT that can cause peripheral neuropathy in the first line, isoniazid, but ethambutol also causes peripheral neuropathy. In the second line, just like linezolid and quinolones, cycloserine, very important to cause peripheral neuropathy. Terazoidone, very important to cause peripheral neuropathy. Bedaquiline, a very important drug that causes peripheral neuropathy. And ethionamide also causes peripheral neuropathy. So do aminoglycosides. So practically every AKT can cause, and I've had patients where I've tried stopping everything, but ethionamide was finally the cause. So please understand that most of the AKT, but this is actually the list. Isoniazid, ethambutol in the first line.
Yeah,
and line,
two causes add peripheral neuropathy, but do not stop all these drugs or that's
so
one thing.
You have to know that linezolid, quinolone, bedaquiline, cycloserine, terazoidone, ethionamide, and aminoglycosides. And basically, as Dr. Vikas rightly said, very often I just get vitamin B12 levels done because often patients have low vitamin B12 levels, and just correcting it makes a patient significantly better. Pyridoxine, we can actually increase to 200 milligrams a day. That also significantly helps in addition to be adjusting our other doses. We can give pre-gabapentin, we can give 300 milligrams a day. Gabapentin can be given 1800 milligrams a day. And I really liked what Dr. Vikas said about whenever we're giving tryptomer 25 milligrams, please look for QTC prolongation, do an ECG in between. So fantastic, clinically very, very important. Thank you, Vikas. Now coming to Dr. Siva, I'm sure he's going to give us fantastic information because he does so much of this and he has so much of experience. So basically, this is very important for us to understand, Dr. Siva, that we have so many tests. We have CBNAT, LPA, Gene Expert XDR, Gene Expert Ultra. So if we already know that patient has INH resistance or rifampicin resistance or quinolone resistance, ethanamide resistance, then can't we just go with these reports? Do we still need to get midget sensitivity, and why? Please explain.
Yeah, thanks for the question, ma'am. Do we need, test like midget culture and DST if we have already got the results of the main results which we'll get is only rifampicin, INH, fluoroquinolone, and aminoglycosides. These are the only 4 drugs. But then we are using certain drugs which have never been tested. Like, for example, pyrazinamide, not tested. Ethambutol, not tested. But then when you go for second-line drugs, bedaquiline, not tested. Linezolid, not tested. All these drugs are not tested. So for DS TB patients or drug-sensitive TB patients who have been given LPA and there is no resistance detected, it is fine to go with the results which you have. But then for those patients who have started developing resistance, it's a start. Probably the mutation rate, and since it has been already exposed to drugs, there are chances of development of other resistance as well. For that, we need to check using liquid culture. So for resistance population, we need to definitely do a liquid culture to test for the panel of drugs. That's what NTP also has built in. For all the resistant drugs, all the resistant strains, we have to do a midget culture. The reports might get delayed, but then you'll get if the treatment fails in the due course, we might have a regimen ready for use. Like for example, when we see H resistance, we do a panel of drugs, including ethambutol, pyrazinamide, moxi, levo, and so on. And when we have R resistance, we grow them and look for again the same drugs. Along with that, we also do bedaquiline, delaminate, clofazimine, and linezolid drugs. So these are the drugs which we do for liquid culture, so that we have a regimen if the patient comes with a failure.
Yeah, wonderful, Dr. Siva. I completely agree with you. If the patient is resistant, DST is a must. But Vikas and me and Kunjal, we practice in Mumbai, and it's very, very frustrating. We are unfortunately the MDR TB capital of our country. So basically, at least in our practice, even if the patient's genotypic shows susceptibility, resistance not seen, we still get the midget susceptibility done. And in about 2% of people, unfortunately, we've actually found that they are genotypic resistance not seen, but we are finding resistance seen in midget. And then we've done pyrosequencing to confirm, or we've done WGS and we found out. So I feel that if the patient is in program, then we completely follow what Dr. Siva said. If you are in a place where not too much of resistance is seen, then we must do what Dr. Siva is saying. But for people who are practicing in Mumbai and maybe other parts of India, which have too much of MDR TB, I think even if resistance is not seen in genotypic, we must insist on midget sensitivity. Because do you also do this?
Yeah, definitely.
Yeah, so midget is something that we always ask for. And as pulmonologists, we just have to do it, because tomorrow if there's a report which is different, then we may get into medical legal problems, So I just feel that what Dr. Siva is saying is correct for microbiologists, but we as practicing pulmonologists, regardless of the genotypic report, because genotypic report only picks up a few mutations, and there are so many more actual mutations, we must ask for midget DST for every patient. Dr. Siva, you think you agree, or you think we are overdoing it?
It is fine if the facilities are available, but then it depends upon the clinician to decide on whether to give or not. And it also depends upon the area where you are practicing. If you already see more mutations there, and if you have certain mutations which you have missed, it goes by the practice. If you have seen that, I have seen around 100 patients, and I have seen around 10 patients whom were genotypically sensitive, but then when I did midget for them, it was resistant. Then probably we have to do it, and we have to also look for what are those mutations which have been missed. Yeah, that can also be done. Yeah.
Correct. So for us, pulmonologists
So after all,
always
we
have
cannot forget that MGIT and midget basically are the gold standards right now. And we have to get it done for all the patients.
we have to do it. Whether facility is available is not right on paper, you have to ask for it. Yeah.
Actually, under the program, it is there as guidelines. In the algorithm, it has been done for each and every patient. Definitely.
Yeah. With INH especially, we've seen that resistance not seen on LPA, but we are seeing INH resistance on midget. We've seen it in particular with INH because there are so many more mutations than 2 mutations that we pick up. Okay, coming to Dr. Kinjal. So Kinjal, MDR treatment in pregnancy, lactation and children. Kinjal, I think we lost you.
Yes, ma'am. I'm there, ma'am.
Hi, okay, great. We lost you in between.
Audible? Yeah, sure.
Okay, I asked the question. If a patient is MDR TB,
Yeah.
how to treat MDR TB in a patient who's pregnant or lactating and in a child?
Yeah, ma'am. Wonderful question. Just before answering that, I'm really grateful to your way of answering questions, because it is 11:15 and people are still stick on to hear the answers of whatever questions you're asking, ma'am. That's really great. These are typical questions, typical conditions of life. Unfortunately, as I told you, prevention is better than cure. Always counsel that pregnancy is avoided, but unfortunately, the pregnant lady gets MDR TB, then we have to handle the situation in the practical scenario. Very specific, we have to see the weeks of gestation. If it is 20 weeks before this 20 weeks of gestation, diagnosed before that, always counsel the family that MTP is a better option, because medications can be given very nicely and better way if the pregnancy is terminated and the risk to the kid also is avoided. If it is more than 20 weeks, then we have the scenario of MTP till 24 weeks, also with the help of High Court. Many times we have done till late gestation also. But yeah, what criteria and guidelines what mentioned presently, more than 20 weeks till 32 weeks, they have a criteria to, with the help of with the help of obstetricians in the date counseling, continue the longer regimen treatment. And if they are not agreeing for MTP many times, then also longer regimen treatment is better compared to shorter regimen treatment to avoid any harm to the kid. Coming to that, we always contraindicate any SLIs, that is any injections during the pregnancy. Now coming to if MTP is done, then patient can be posted for shorter regimen therapy if there is all the inclusion exclusion criteria met. Coming to lactation part is more or less the same, but generally the bedaquiline and diluminate can only be given if the patient shifts on a formula feed for the kid. So breastfeeding, if it's avoided, then patient is like simple other patients, and it can be treated like on either shorter or longer regimen, either of them. Coming to last part of my answer, that's pediatric population. They are a very cliched population. The drugs till now we were not available, but now with the help of all the guidelines coming up, till the age of till from the 5 years and above, bedaquiline can be given. Below 5 years till 2 years, I think diluminate is available. But either of them, basically, we have to be always understanding that the regimen remains the same as in adults. Generally, the results are not as good as they say because of the adverse reactions coming up. But we will always be in consultation with the pediatric about the dosing, because the pediatric dosing is very difficult. As also the formulations for the pediatrics are different. Easily child-friendly formulation should be there, which generally is available in the program, but you have to get it for the patient in particular. And pediatric population, as you all know, that basically monitoring side effects and everything for the pregnancy, also basically TSH, USG more frequently are required to just look at the fetus if there is no side effects or any complication occurring to fetus. Thank you.
Okay, Yeah, so this was really very good. So lactating pregnant women, you have to use longer bedaquiline because we can't give ethionamide. And children less than 5 years of age, we don't give bedaquiline. So more than 5 years of age, bedaquiline, but delavanide is given even for younger children. So great, this was super.
Yes, ma'am.
Coming to Komal. Komal, tell me, how will you treat MDR-TB in patients of liver disease?
Madam, in case of renal and liver failure, in cases of MDR-TB, the first, the drugs which can cause renal failure are ethambutol, levofloxacin, aminoglycoside, cycloserine, and PAS. So first, we need to do proper pre-treatment evaluation. That is a must, whether the renal or liver disease was present before, or it is concurrent, or it is secondary to the anti-TB treatment.
Actually,
in case of renal failure, when the
Komal, sorry. Actually, these medicines get excreted by the kidney. These, except for aminoglycosides, these medicines are not nephrotoxic. I think you said something different. So these medicines get excreted exclusively by the kidney, and therefore you want to find out the part before clearance before you decide to give them. So I actually asked about liver. I didn't ask you about the kidney because I just want to wind up.
Okay, so I just.
You were
okay, ma'am. Sorry, I just.
Yeah, patients of liver disease. How do you treat them? MDR-TB.
So usually isoniazid and pyrazimide, ethionamide, and bedaquiline are the drugs which can cause the liver disease. And again, we have to do the pre-treatment evaluation properly, whether the patient is having already having some liver problem or it developed after the starting of the treatment. So as we say, if the enzymes are more than 3 times in a symptomatic patient, or if the enzymes are 5 times and higher in asymptomatic patients, we call it as liver AKT-induced liver failure. And in that case, yes, ma'am, you want to say something?
Yeah, that is when patient is on rifampicin, right? So we are on MDR treatment. Yeah. So patient will not be on rifampicin.
Correct. So maybe, ma'am, you can correct me.
No, Dr. Komal was actually correct. I think she just got a little confused. She very correctly said that, the shorter regime has a lot of hepatotoxic drugs like isoniazid, pyrazinamide, ethionamide. So if the patient has significant liver disease, then we want to give them longer bedaquiline regime.
Longer. So yes, we can shift the patient to the longer. And in longer, if we are finding any culprit drug, then we can replace the drug as per the
Absolutely. Very well said. So if patient has significant liver disorders, then don't put them on shorter, put them on longer regime because we have, we are flexible to. Great. Dr. Ratan, I want to ask you a very important question, which I feel you can really throw some light on, and a lot of us are really going to learn things about it. So can you please tell us what is BD-MAX MDR-TB assay? How do we compare the rifampicin and INH resistance patterns on BD-MAX MDR-TB with CBNAT and with LPA, GeneXpert, XVR, etc.? And what are the advantages of BD-MAX over the other genotypic tests? Because I think it's a very important test, but somehow not many people are using it or not many people are aware. So can you please throw some light on this?
Yeah, as you know, that BD-MAX was one of the 4 moderately complex tests approved by WHO in 2020. And the trial was done in Pune as well as Africa and other countries. And the advantage is that this is high throughput in the sense that it will give you, it can do 24 samples at a time rather than 4 than GeneXpert can, but less than others which can do 96. So this does 4, and it detects both, it reports on INH as well as rifampicin, besides detecting Mycobacterium in one run itself. So the report will tell you whether Mycobacterium tuberculosis is present or not, and whether it is INH susceptible and rifampicin susceptible. The advantage here is it can be done on raw sample as well as in process sample. And it's been tested, as I said, with Indian isolates, with African isolates, and they find that the reproducibility, that the LOD was 0.5 CFU per ml. So we're saying it can pick up one bacteria because it has multiple targets, and the targets are present in multiple number in the gene of Mycobacterium. So it's more sensitive than any other test available. In resistance, it has more than in reporting, it has more than it's 100% concordance with smear positivity, but that's not too far away. But in resistance with INH and rifampicin, there's more with existing mutations. There's more than 90% concordance in the field trials. So overall, there's speed. There is it's automated. It gives simultaneous reaction, so that, and in 75% of the samples which are drug sensitive TB, nothing else needs to be done. You have Mycobacterium tuberculosis, you have INH susceptible, rifampicin susceptible. Now treat with routine method. If there's drug resistance, then of course more things need to be done.
Yeah, but I basically feel you are very right, fully agree. I think many advantages. For example, only one organism can be picked up as against Gene Expert Ultra. We are so happy that 16 CFU per ml. Over here, it's only 1 CFU per ml. And it's one test. Basically, otherwise we do CBNAT, we come to know about rifampicin. And then we have to do about LPA. So it's a second test. Sometimes sample is not available. Sometimes reports take more than 2 weeks. Sometimes reports never come of LPA in some areas. So over here, upfront, one test tells you about rifampicin and INH. So I think it's extremely important. And you can do it even on a smear negative.
The false positivity of BDMAX?
So BDMAX,
BDMAX is costing us nearly the same as Gene Expert. See,
false positivity.
Some of them is subsidized.
Yeah, so actually the thing is that the matching is actually very, very good. So basically the thing is that if you compare it with other genotypic tests, then the concordance is about 96 to 97%. And WHO has already accepted this, but somehow I think program has not taken it. So actually I'm planning to give it to as a thesis topic to one of my patients.
I think if you look at the disadvantage, then the disadvantage is that it is a bigger instrument, so it will be centralized. See, your aim is to decentralize.
It's basically like a cartridge-based test, no? So there won't be a problem, right? In like LPA, sometimes there is inter-reader variability, whereas this is like a cartridge-based test. So positive is positive, negative is negative, which is an advantage, I feel.
That's true. That it is automated. It's automated. Hands-on time is only half an hour for all the samples, and you can report 24 in 4 hours time. So that means 2 runs can be done in a day.
Positivity.
Cost.
False positivity of
false positivity.
False positivity. Yeah.
No, so as per the printed literature, it is saying that the sensitivity with the midget, the concordance is 96 to 97%, which is similar to CBNAT. And
see, I understand what you're looking for is because in Ultra you had trace, and trace would cause a lot of trouble. The trace is because in Ultra the target is RPOB gene, and there's only one RPOB gene.
Dr. Ashok, Dr. Vikas was asking a different question. It was from a clinician point of view. So he was basically saying that what is the false positivity, means if the results are reliable or not.
See, false positivity will be when you're talking about trace.
Dr. Siva also. Dr. Siva has raised his hand. Can you say something, Dr. Siva?
The false positivity rate is around 3.5% for BDMAX.
No, still less, still better. Okay.
Yeah,
it's better. That's why I said that it's 97 to 98. It's matching more with midget. And actually, I've gone through the data and I'm planning to give it as a thesis topic to my student. Compare Gene Expert with LPA, with midget, with BDMAX. And we'll see 50 patients. And then I just feel that, one test is better than 2, especially if it's a sputum, because sample is limited, or if it's extra pulmonary TB. We don't get enough sample, then one test would be definitely good. So I think this would be something really useful. Fine. Vikas, I'd like to ask you a question. I think maybe I'll keep this as the last question, because actually we have more and more questions coming from the audience, but it's almost 11 o'clock now. So one last question, and or maybe, I'll ask this question to everybody, starting with Dr. Vikas, because it's something very close to my heart, and I genuinely mean it. So unfortunately, Dr. Sanjeev is left. So because this question I had not planned to ask you, I planned to ask Dr. Sanjeev, but I'll ask you. Yeah, but you know, you are a TB champion, so of course you'll answer. And we're going to ask all our esteemed panelists about the same. So basically, the thing is that we all know that the problem of MTB is that the minute it's exposed to AKT, it becomes dormant. And when the TB germs are dormant, whatever medicines you use, they can't be killed. And these TB germs have intermittent bouts of activity, and only when they are active can the AKT kill the germ. That is the reason we are giving AKT for a longer period. It's not to cause a quick cure, it is to prevent a relapse. So honestly speaking, and I'm very genuinely speaking of my mind, I just feel that if I were a patient, I don't want to take a shorter regime. When I am unwell, I want to take a treatment. I want to complete the treatment, even if I have to take it for a longer period, but I never want to get the disease again. So if I have to take shorter bedaquiline versus longer bedaquiline, I will always want to take longer bedaquiline or give it to my relative. I will never give BPAL unless there's no other choice whatsoever from susceptibility point of view. So I just want to ask each of y'all, you know, because I feel that at places, I mean, I just want to really say that at smaller places, the program has been told that you need to enroll so many shorter bedaquiline, and therefore they're going out of the way to enroll patients. And these patients are actually relapsing. And so, okay, so Vikas, what do you have to say about this? And this is honest talk.
Yes.
This is sad
So
talk.
as I already mentioned in my talk, was 4 points that, you know, it should be shorter regimen, lesser number of drugs, good compliance, lesser ADR, everything is good. But only worrying factor with these shorter regimens are relapse rate. You need to be very careful, very cautious. The patient should be under close follow-up. With the patient should not get relapse is the only challenge. So whichever regimen you give, the shorter or the longer, there are relapse with even longer regimens. It's not that the longer regimens don't have relapse. So even relapse are being seen in longer regimens also. But if any regimen is being,
speaking,
if any regimen,
for yourself between shorter and longer, what would you choose? Honest.
Yeah. So if been given to me shorter and longer, I would definitely go with shorter. Also, if the DST, if I am having a perfect DST, if I am having a good LPA, I am having a DST of bedaquiline also, linezolid also in along with me, and then I would see the baseline and the end before any treatment is very important. The mistake what we all do is in field is guidelines mein likha hai 6 months, you stop the treatment 6 months. Don't do that. You need to evaluate a patient at the end of the treatment is very important. First thing. Second thing, once evaluated that you are thorough now, yes, the patient is confirmed negative, CT scan is good, cultures are negative, no symptoms, asymptomatic, patient weight gain, no fever, everything is good. Repeat a radiological diagnostic investigation after 6 months. It's very important. So if I see, ma'am, in my own experience in shorter regimen, that is BPAL regimen, the relapse, if you see in entire 84, out of 84, 3 have relapsed after 2 years of stopping the treatment.
After 5 years?
After 2 years of stopping the treatment. Yeah. So after 5 years, that's the reason the country is still not rolling out the shorter regimens. Maybe the country is waiting for the data to get gathered, to be collected of relapse of all the patients of 400.
Okay. I basically feel that even if the germ is
shorter versus BDQ longer, if you ask me, ma'am, the Bangladesh regimen which was there, now the study has already been done somewhere else. We don't have our own data. Now that is the problem. We are lacking data right now. We need good data. That's the reason we need to have a good data with us. Nikshay is doing a fantastic work right now. We are just in process of generating a data of all the Nikshay who have been enrolled under the short course regimen and study the relapse rate of these patients. And then only probably we would be able to say that even 5 years after stopping the treatment, the patient relapse rate is less. I would say shorter BDQ is also working maybe.
Correct.
But provided LPA should be placed, DST should be there, patient compliance should be good, follow-up should be good. That is very important.
Okay, fine. I basically just feel that even if you do everything, if the organisms are dormant, everything's going to be good. You're going to put on weight, your CT scan will be fine, the smear will be negative. So basically, whether organism is dead or dormant, usually I would like to ask Dr. Ashok, let's see what he has to say. What do you feel, Dr. Ashok? And let's be honest. Let's talk rural medicine.
in this, I'll take you back to when I was in academics. There we had evidence that once you start the treatment, then the bacteria, which is maybe 10 to the power 6, will come down to 10 or so within 1 month of treatment.
Absolutely.
Thereafter, you're giving, and they have become dormant. And thereafter, you're giving the treatment in our time when we were students for 16 months and now for 6 months, hoping to prevent relapse. But the bacteria is inside the macrophage and dormant. So whether you give for 6 months or you give for 16 months or 18 months is not going to make. So what you have to do is to irritate the macrophages so that the macrophages get active and will attack the bacteria inside and make them extracellular. And that we had tried with, we had initially thought we will do with Mycobacterium vaccae. So you give a vaccine. So you give 1 month of treatment, give a vaccine so that the macrophage get activated and the bacteria becomes extracellular, and then you give another month of treatment so that those which have become extracellular can not be wiped out. I remember at that time I was in Dundee, and then on coming back I met Grange, who was the editor of Tubercle at that time, but they had done some study in some African country and not got good results. But theoretically, that needs to be pursued, at least in the academic circles, that you get something to activate the macrophages so that the dormant bacteria become extracellular, and then give another month and wipe out. So then it's possible to have a vaccine in between, 1 month of treatment, vaccine, another month of treatment, and you've wiped out all the bacteria. That's a theoretical concept. It has failed with Mycobacterium vaccae, and therefore, of course, after that I left academics and now in a different scenario. But I think
interesting. I'd like to ask Dr. Siva. Dr. Siva, what do you feel, being a microbiologist, about this dormant point? Logically, what do you feel? Taking sensitive AKT again is different as against taking resistant toxic AKT all over again, and the stress of having MDR again is stressful. What do you feel? Should we prefer longer or shorter regimes?
In continuation with what Dr. Ashok said, so to wipe out this latent bacilli which is sitting inside the macrophage, we have to try other methods rather than continuing with the same drug, because we do have tried certain other adjunct therapies like efflux pump inhibition, or where you can introduce these antibiotics in a more proper way into the macrophages, or activating autophagy as a pathway to kill the macrophages which are there inside. I mean, you activate a pathway inside the macrophage so that it kills the bacteria, and of course it gets destroyed. But then those are other methods which have been tried out, and clinical trials are going on. I mean, we are also doing with metformin and verapamil to see the relapse rate and other things, but then it is on the initial stage of studies.
Okay, interesting.
I think they also tried metronidazole. Metronidazole had some activity against dormant.
Metformin has been found to be a very, very good adjunct drug, which basically allows the TB germ to die faster and also prevents its relapses, and it helps in sterilization. So a lot of drugs are tried. I just hope something works. What about Kinjal and Komal? Quick answers. What do you all think about shorter versus longer?
Madam, it's a very catch-22 condition at present. Just I will answer very shortly that we have to see the drug-sensitive treatment part of it. We know that it was a very wide experience. So basically, we had initially the TB sanitary treatment coming to some kind of septomycin-induced therapies. Then for last 1990 onwards, we had typical therapies for it. So we had almost 6-7 decades of information for drug-sensitive TB. For drug-resistant, we have hardly less than 2 decades of information and proper management done. So from the depth of my heart, basically longer regimen was just, we know that it's arbitrary. 24 months was initially, then it was reduced to 18 months nowadays. But still, that even people feel like that 18 months sufficient. Should we continue more at the end of 18 months? So there is no end to it. So we need more data, basically, that shorter regimen are very effective. And follow-up studies, as Dr. Vikas told, that basically follow-up has to be done. But present scenario, if you ask me, very simple answer, at present scenario, longer therapy, yeah, better for the perspective of that our resistance may relapse in that cases. But shorter regimen are failure always, it is not the case, ma'am. Because we have given in the program and people have responded very well with that also.
People have extensive TB. When people have CNS TB, you're not allowed to give shorter Why is it so?
So all those criteria, if they are not matched, then definitely shorter regimen doesn't come in picture, ma'am.
Extensive TB, there are more number of bacilli. So more bacilli are going to go into dormancy, and therefore longer treatment is no help. So I think if we know the subject, and the thing is that, when shorter beta-pillin regime does not even have a 5-year decent follow-up literature, I don't think we should be rolling.
We don't have. There is small studies in Bangladesh and all those things. Indian studies to come up with we have huge data, basically.
Our field we had a 48% success. When it is published to be 85%. So I basically just feel, Komal, what do you feel? I think after this we should.
Ma'am, I also yes, I also feel that longer is better because we don't have enough data. So we need to keep a proper follow-up. And for now, when clinical trials are going on and we don't have the data, longer should be the better option for the dormant bacilli.
Completely with so. I think out of all the answers, at least I don't know who's right, who's wrong, but I find you to be like a correct answer from them all. Anyway, I just want to say that it was a fabulous session today. We have more than some 1556 logins last seen. I have to see the final number. I've not been able to check. But I just feel state-of-the-art talks. Dr. Ratan was fabulous. Dr. Vikas was awesome. Dr. Sanjeev Nair was fantastic. And I'm so grateful to all our 3 panelists. Dr. Siva, you were fabulous. Actually, I want to ask you many questions about what is new in the program, but probably when I meet you, because you'll give us so much more information. Kinjal, what I really liked about you was you were just so clinically based and, like you had very, very good answers, which are like tips and tricks for common practice. So that was wonderful. And Komal, it was very, very good. Your answers were pulmonology, infectious diseases, and you had your inputs to give. I just feel fantastic inputs by Komal, Kinjal, Dr. Siva, and our 3 speakers. And a big thank you to Indian Chess Society and BD. Nitin, I'm so grateful to you for all the pains that you've taken. But I think we've had a fantastic session. And the last question number is 48. And questions are still coming. So thank you so much. We are at a session. We'll call it off now. Okay. Good night. Thank you.
Thank you, ma'am.
Thank you so much.
Thank you. Thank you, ma'am.
Thank you, ma'am.
Yeah.
Thank you.
Yeah. Bye.